Hello everyone, welcome to the revision marathon series of Study Medic. Let me introduce myself. I am Dr. Shamni, one of the mentor from Study Medic. And today we have our fourth session and we are going to cover the whole of gynecology module in 2 to 3 hours. Let's see how we can do this. So let me discuss the agenda. Agenda of this is basically we are trying to revise the whole of gynecology module, the most important exam tested areas, and we'll be discussing the most important confusing questions also in this session. So basically we are going to focus on these topics, which includes HMB, fibroid adenomyosis, endometriosis, PCOS, and we have to discuss about amenorrhea, chronic pelvic pain, endometrial polyps, premenopausal, postmenopausal, adolescent ovarian cyst, as well as pregnancy and ovarian cyst. A little bit about AUB and its workup, vulval conditions, menopause, the new guideline is there. We'll be focusing on that as well, and premature ovarian insufficiency. Insufficiency. And after that, we will discuss some EMQs also. So I just want to tell you that these are the most highest yield areas, yield topics, and this also the second box also shows important topics from which you are supposed to get lots of questions for your exam, and you should have good understanding about topics like chronic pelvic pain, endometrial polyps, vulval conditions, etc. So today we'll be focusing on these topics. Let's see what we can do. So let's discuss the first, the most important topic, like I should say, it is heavy menstrual bleed. So the most important points. One is, see, earlier we used to tell that HMB, heavy menstrual bleeding is this much, more than 80 ml bleed is this HMB. So nowadays that definition has changed. So nowadays it is defined like any amount of menstrual loss which will interfere the patient's physical, social, and emotional quality of life. It is not focusing on the volume of the bleed. So this is the most important changed definition, and you should understand this. And see, in NHS, whenever a patient comes with heavy menstrual bleed to your clinic, so generally what all we do? We generally send for investigations. We will examine, we'll take a detailed history, examine, then send investigation, then we'll start treatment. But in your guideline, things are little different. So I just want to tell you that if a patient comes with heavy menstrual bleed, with no complaints of intermenstrual bleed or any other symptoms suggesting any abnormality in the cavity, then you may start her directly with the treatment, which is tranexamic acid. So she should only have heavy menstrual bleed. She should not have postcoital bleed. She should not have intermenstrual bleed. She should not have any pressure symptoms. Okay. So if at all the complaint is just heavy menstrual bleed, you may start directly tranexamic acid. You need not examine the patient also. Okay. You need not examine the patient also. When will you examine the patient? You will examine the patient if you're planning to put LNG-IUS. We all know that the first line treatment is LNG-IUS. So only if the patient denies LNG-IUS is not fit for LNG-IUS, we will go with the second line treatment, that is tranexamic acid. Okay, so just to start tranexamic acid, there is no need to examine. You may just start directly. But for LNG-IUS, you have to do a pelvic examination. That is a must. Correct? Now, what about investigation? A patient is coming to you with heavy menstrual bleed. Would you send all the investigations? Which investigation will you send in the beginning? Okay, so it is full blood count. Full blood count. This is the investigation which you can do in the initial visit itself. Okay, just full blood count. You can send it, no problem. What about coagulation screen? Will you send it for all the patients? No. You will send it only if the patient's history is suggesting some bleeding disorders. For example, she has been having this heavy menstrual bleed since menarche. And she's giving history of any bleeding into joint, other bleeding problems, any like bleeding from the gums, or anything which suggests any bleeding disorders, or if there is significant family history. then you may send coagulation screen. Otherwise, routinely, it is not needed. Okay. And what about thyroid, ferritin, hormonal studies? These things are also not needed routinely. But if the patient is having symptoms of hypothyroidism, yes, you have to do TSH. If similarly, if the patient is having any other like suggestive symptoms or signs suggesting some problems, then you may carry out other investigations. Otherwise, routine blood investigation, it's only full blood count. No need for TSH, no need for ferritin, no need for any other tests like hormones. But yes, if the symptoms are suggesting hypothyroidism, you have to do. So I just wanted to focus that point. Now, always there is a confusion. What to do next? Ultrasound or hysteroscopy? What to do? So that depends on the symptoms of the patient. Okay. And also your examination findings. So suppose if the patient complains of some problems like persistent intermenstrual bleed or any other problem, her history is suggesting some problem with the cavity, then you have to do a hysteroscopy. That is a must. We will talk in detail regarding the proper indications of hysteroscopy and the biopsy also. But yes, basically it means that if the symptoms or signs suggest something, there is some problem in the cavity. If you're doubtful, then you may go ahead doing hysteroscopy. If on examination there is a pelvic mass, then you need ultrasound. If the patient is complaining of more of like pressure symptoms, and on examination you're feeling that the uterus is enlarged in size, or there is some pelvic mass, or it is she's an obese patient and you're not able to make out anything. You're not able to make out. So examination is inconclusive. These situations, you can go ahead with an ultrasound, pelvic ultrasound. Correct? So basically hysteroscopy or pelvic ultrasound, the investigation will depend on the history examination. So you can see here that first line investigation hysteroscopy if it's suggesting some endometrial cavity problem like submucosal fibroid, polyp, or any endometrial pathologies. Basically, you should understand that hysteroscopy is more sensitive than ultrasound. And pelvic ultrasound if the uterus is palpable or some mass is there during your examination, or in obesity also you can do. Always understand that TVS, transvaginal ultrasound, is the preferred ultrasound. Transabdominal ultrasound can be supplemented if the pelvic mass is heavy, like very big. So if in the question you see that there is a 12 centimeter mass, pelvic mass, then see with just TVS alone, you won't be able to understand it completely. You have to supplement it with transabdominal scan. So based on the question, you have to select the answers. Correct? Based on the questions. So I'll just repeat. If the history, science, and history and examination suggest some cavity problems like polyp, submucous fibroid, your next investigation becomes hysteroscopy. If it suggests some pelvic mass and if the examination is suggesting some pelvic mass, if the uterus is palpable, then or if the patient complaining of pressure symptoms, then your next investigation becomes ultrasound. So mostly you have to write transvaginal ultrasound. If in the question they specifically mention that it is a big mass, big pelvic mass is there, then if at all you see an option TVS plus TAS, you select that. So transabdominal scan, basically it is used as a supplement with the transvaginal scan in bigger mass. Always understand whenever you are doing biopsy in reproductive age group HMB, heavy menstrual bleed in reproductive age group, and you're supposed to do endometrial biopsy, always go for hysteroscopic biopsy. No role for Pipelli or blind biopsy here. It is little contrary with the postmenopausal bleeding scenario. So always candidates get confused here. So generally for postmenopausal bleeding, what is it? The first line investigation, it is always Pipelli, right? The patient will complaining of postmenopausal bleeding, you will do a scan. If the endometrial thickness is more than or equal to 4 mm, you are going to do a Pipel biopsy, except in certain conditions like if the ultrasound is having fluid, if the endometrium is heterogeneous, if there is a polyp in the endometrium, or if the patient is having some risk factors for endometrial CA, then you will go for hysteroscopic biopsy in a postmenopausal bleed. But a postmenopausal lady without any risk factors, if the ET is more than or equal to 4 mm, you are going to do PIPLE. I just told that because you should not get confused. But in reproductive age group, what we are discussing now, it is reproductive age group HMB. And if at all you are doing a biopsy, it is always hysteroscopic guided biopsy. Should not be any doubt about this. Okay, it is always a hysteroscopic guided biopsy. And regarding ultrasound, yeah, it is said, I have already discussed this point, that TVS should be the preferred ultrasound. Okay, suppose the patient is complaining of HMB pain and you're thinking of adenomyosis, then also you go for a TVS. Okay, so that's all regarding the most important points of HMB. Now I will focus which all patients should need endometrial biopsy. So as I told, if the patient complain of persistent intermenstrual bleed, just note this term, persistent intermenstrual bleed, or there is irregular bleeding, infrequent bleed, heavy bleeding. So suppose patient says, I did not get my periods for 3 months, then suddenly I had heavy menstrual bleed. Then also you have to do a hysteroscopy. If the patient is having any risk factors for endometrial CA, like obese patient, obesity, PCOS, if the patient gives history of tamoxifen intake, these are all risk factors, right, for endometrial CA. Now another group of patient on whom you tried medications, you tried hormones, everything you tried, it's not working. HMB, treatment for HMB is unsuccessful. In those group also, your next step should be a hysteroscopic guided endometrial biopsy. So if you get two options, one is endometrial biopsy and another one is hysteroscopic guided biopsy, go for hysteroscopic guided biopsy. Correct? Go for hysteroscopic guided biopsy. So biopsy at hysteroscopy, I will repeat, it is done basically if the patient is having persistent intermenstrual bleed or irregular bleeding, infrequent heavy bleeding, obese patients, PCOS, which is a risk factor for endometrial CA, taking tamoxifen, which is also a risk factor for endometrial CA, and in whom HMB treatment was unsuccessful. You are going to do a hysteroscopy guided endometrial biopsy. See, initially in the guideline, they used to focus on this age. You can see here the age. Cutoff was more than or equal to 45. But now that has been removed. Now there is no 45 more than 45, nothing like that. Basically, it is nowadays we are focusing on the risk factors, which I mentioned, like obesity, PCOS, tamoxifen, etc. And if at all you are suspecting cancer, 2-week referral pathway. Go for 2-week referral pathway. Fine. So here, basically people will get confused between this blind biopsy and hysteroscopic biopsy. So don't forget that. And intermenstrual bleed, it is not single episode of intermenstrual bleed. Remember, it is persistent intermenstrual bleed. Okay. So don't get confused. Persistent intermenstrual bleed. Now let's discuss about the treatment of HMB. So if at all the patient is having HMB, no or a small fibroid of less than 3 centimeter. The cutoff is important, less than 3 centimeter. Or the patient is having adenomyosis. In any of this scenario, if it's just HMB, no, nothing else is there, everything is normal, only heavy menstrual bleed is there. Fibroid is there, but it's less than 3 centimeter. So less than 3 centimeter is unlikely to distort the cavity. It is very small fibroid. Or if the patient is having adenomyosis. In these situations, you can go with our famous, very good friend, that is LNG-IUS. But you have to make sure that cavity is not distorted. So some people ask, so suppose there is a submucosal fibroid, 2 centimeter, Are you going to put it or not? You can put, because 2 centimeter fibroid will not distort the cavity. It is generally taken like that. Less than 3 centimeter fibroid is not going to distort the cavity. So the first line in these situations become Mirena. So if at all in the question you see any of the scenario, you can choose LNGIUS. But sometimes situation can be little tricky also. If the patient wants fertility, patient is having some complaint like HMB, less than 3 centimeter fibroid or adenomyosis. She wants to conceive. She's planning to conceive. So you won't give LNG IUS for patients who are planning to conceive, right? So what else become important? You have to ask her plan for fertility, whether she's planning to conceive or not. That history becomes very important. So if at all she's not having any plan, you can very well go ahead with LNG IUS or Mirena. Now, in certain situations like which I discussed now, patient is planning pregnancy or any other condition where she decline LNGIUS, it's not suitable for her, she's not accepting it. In such situations, you can go either with the non-hormonal method or the hormonal method. So, what are the non-hormonal methods? Like tranexamic acid, mefenamic acid or NSAID is also another option. So, like in the question, if you get pain with heavy menstrual bleed, so don't choose tranexamic acid. You can choose, if at all LNG IUS is not acceptable or not suitable, you want to choose something else. Hormone is also not suitable. Then what will you choose? It is not tranexamic acid. You will get two options. Option A, tranexamic acid. Patient is complaining of heavy menstrual bleed and pain. So option B is mefenamic acid or NSAID. Choose NSAID or mefenamic acid because it will help in controlling the bleeding as well as the pain. Correct? It will help in controlling the bleeding as well as the pain. So non-hormonal methods like tranexamic acid, mefenamic acid, NSAID, or hormonal methods like combined OCP, cyclical oral progesterones, these are all the treatment options for HMB. And this much GP can do, okay? LNG, IUS, non-hormonal, hormonal, this much GP can do. But the symptoms are persisting. Then what they have to do? They have to go for a specialist referral. So this is also important. When will you refer to the specialist? LNG, hormonal, non-hormonal, after trying this much only you will refer. Okay. So specialist referral, reinvestigate the case. You have to refer, they have to reinvestigate the case. Other options are also there, like second generation endometrial ablation, definitive treatment like hysterectomy. And remember, in the questions, you will get a patient wants definitive treatment. She is completed family. If at all they mention the term definitive, you are going to choose hysterectomy. So search for all these keywords in your question. Wants definitive treatment, completed family, not willing to remove the uterus. So all these patients you are going to choose hysterectomy. Now, there comes a confusion. Patient is having 28-week fibroid. She wants definitive treatment. She has completed her family. One option is hysterectomy. Another option is GnRH followed by hysterectomy. So, which one will you choose? You will choose GnRH followed by hysterectomy. Why? Because GnRH will help in shrinking the size of the fibroid. So we can save bleeding, we can prevent bleeding. So it will help in building patient's hemoglobin. So if at all in the question they have mentioned anemic patient, so go for GnRH followed by hysterectomy. So two options will be there, either hysterectomy or GnRH followed by hysterectomy. You will choose GnRH followed by hysterectomy. Correct? So don't get confused. Search for all the options and then only you select your answer. And remember, if you're giving GnRH also, maximum for 3 to 6 months only you will give, not more than that. Sometimes just to confuse you, in the question they will give two options. One is hysterectomy, 28-week fibroid, wanting definitive treatment, willing to remove uterus or completed family. You want to choose hysterectomy. In another option, there is GnRH followed by hysterectomy. So now you know that we have to choose GnRH followed by hysterectomy. But third option, no, second option, instead of GnRH followed by hysterectomy, they have mentioned GnRH for 12 months followed by hysterectomy. If it is mentioned like that, don't choose that option. Go for hysterectomy only. Choose hysterectomy only. Why? I will tell you. Maximum GnRH you are going to give for 3 to 6 months only. Beyond 6 months, it is now going to cause several problems, side effects, and generally after 6 months you start the add back therapy also, right? So if in the option it has mentioned GnRH for say 12 months followed by hysterectomy and another option is hysterectomy, you will choose hysterectomy. If at all you get another option telling GnRH for 3 months followed by hysterectomy, I would want you all to choose GnRH for 3 months followed by hysterectomy. So, see, the answer changes depending on the question and the option. Okay, so go through all the words. You have to be like scrutinizing each and every word of the question and the options also, so that your answer will be correct only. Okay, now this is also important. Sometimes these figures are asked for the exam. Like, for example, the treatment, okay, the comparison of the treatment, like LNG-IUS generally decrease the fibroid by 30%. And it decreases the heavy menstrual bleed by 70 to 100%. And another advantage is like that it can be used as a contraception as well. So similarly, tranexamic acid will decrease HMB by 30 to 50%. NSAID will decrease it by 20 to 40%. COC decrease by 40%. Oral progesterone high dose especially 60% decrease. GnRH plus or minus add back, it will generally, because it generally causes amenorrhea no, in people. So 60 to 100% is the rate in decrease of HMB and it will result in amenorrhea in 80 to 90%. Progesterone implant or injectable. Nowadays, this is not used as a treatment modality for HMB, but earlier DMPA was used as a treatment. But nowadays, we need not remember that. But nowadays, this is not being used. You should know. And these figures are also very important. Reduction in the fibroid size as well as the reduction in HMB by various treatment options. So, let's discuss the keywords. HMB acute or initial management, and they are awaiting workup. Acute episode, you are not going to put LNG-IUS, right? Acute episode, you will definitely start tranexamic acid only. Okay, so as I told, you need not examine the patient. So first thing, without any workup, what you can start safely is tranexamic acid. First line is always LNG-IUS. First line, unless it is contraindicated. First line is always LNG-IUS. But for acute episode, you are not going to put LNG-IUS. It is tranexamic acid. Don't get confused. So acute episode, tranexamic acid. First line, LNG-IUS. Situations like less than 3 centimeter fibroid, cavity is not distorted, go for LNG-IUS. More than 3 centimeter fibroid, and in the question, sometimes they would mention like anemic patient HB 10.2. These are the classical terms, what they mention in the question. Age-old questions, and the answer is going to be ulipristal acetate. But according to the recent guidelines, we have restricted the use of ulipristal acetate, and it is only used as an interim treatment now. Ulipristal acetate, because of its variation on LFT, abnormal side effects on the liver, we are using it like restricted only. There is only restricted use of ulipristal acetate now. Less than 3 centimeter fibroid, less than 10 centimeter size of the uterus. Family is complete. Okay, and other options are all already tried. She has tried everything, it's not working. Now she wants the next level of treatment. Fibroid is less than 3 centimeter. Size of the uterus is less than 10 centimeter. Answer is going to be endometrial ablation. In other words, I would say that For endometrial ablation, make sure that family is complete, because pregnancy after endometrial ablation is a disaster. It can result in many complications. So make sure that family is complete. And also, after endometrial ablation, you will ask the patient to use some contraception. Okay, she should avoid pregnancy at any cost. And it is generally used for patient with uterus less than 10 centimeter only. Generally used for patients with uterus less than 10 centimeter. And before endometrial ablation, you should rule out any endometrial pathology. So always do a biopsy. So always do a biopsy prior to endometrial ablation. And more than 3 centimeter fibroid, if the patient is having, you can't do endometrial ablation. So less than 3 centimeter fibroid, size of the uterus less than 10 centimeter, family complete. Choose endometrial ablation. More than 3 centimeter fibroid, family complete. Pressure symptoms are there. See, this is the keyword. Most of the question you see, whenever they mention this keyword, the answer is going to be this. Okay. Pressure symptoms. Wants to avoid surgery. Big fibroid, more than 3 centimeter fibroid, and family complete. Such situation, what you will choose? You are going to choose uterine artery embolization. Uterine artery embolization. So basic keywords are pressure symptoms, wants to avoid surgery, family should be complete. Why? Because we don't have much studies of pregnancy after uterine artery embolization. So it seems that if the patient gets pregnant after uterine artery embolization, they can have PPH, placenta accreta, and all those complications, and not much studies also. So it has to be used with caution, or generally we try to avoid it in patients who is desiring fertility. So family complete, wants to avoid surgery, pressure symptom, big fibroid, choose uterine artery embolization. More than 3 centimeter fibroid, bigger fibroid, wanting fertility. Wanting fertility. What you will choose? Myomectomy. Okay. More than 3 centimeter, wanting fertility, you will choose myomectomy. Laparoscopic myomectomy is the best option for people who generally wish for fertility. Now, in a question, they are mentioning a bigger fibroid, family is complete, definitive treatment. I already mentioned this. Definitive treatment, go for hysterectomy. Go for hysterectomy if it is mentioned definitive, right? And submucous fibroid. If there is a situation of submucous fibroid, see the size of the submucous fibroid. If it is less than 5 centimeter, go for transcervical or hysteroscopic resection of the fibroid. So in the question, they would have mentioned a lady, 28-year-old lady, has 6 centimeter fibroid. She wants surgical management. She's wishing to conceive. So one option will be laparoscopic myomectomy. Second option will be hysteroscopic resection of the fibroid. So don't choose laparoscopic myomectomy. So sorry, don't choose hysteroscopic myomectomy resection here because it is 6 centimeter. So for you to choose hysteroscopic myomectomy, always make sure that the submucous fibroid should be submucous and the size should be less than 5 centimeter. So always for submucous fibroid less than 5 centimeter, choose hysteroscopic resection, not lap myomectomy. But more than 5 centimeter, you won't be able to remove it through the hysteroscope. So transcervically, you won't be able to remove. So don't choose that option. So see the size, then choose. And obviously, it has to be submucous. Okay, now let's try to answer this question. A 38-year-old woman has HMB affecting the quality of her life. There is no intermenstrual bleed, no pain. Examination, ultrasound, everything is normal. Completed her family but wishes to retain her uterus. What is the first line treatment? Okay. First line is always, as we mentioned, it is LNG IUS. Correct? It is always LNG IUS. And she has completed her family also. So that's a contraception, right? So there is no problem in choosing LNG IUS. Here the answer becomes LNG IUS. Okay. So when there is no pathology, cavity not distorted, this is the first option. Because the quality of life is generally very good after you put LNG IUS. It is uterine sparing. So all these advantages are there. So we have completed our first topic, heavy menstrual bleed. So if at all you have any doubt, you can write in the chat box. So we'll be saving all the doubts and we'll be addressing it on a later day, probably tomorrow or day after. So next topic is fibroid and adenomyosis. So this is a very important area where we have to where we'll be discussing about the FIGO classification. So basically, FIGO classification of leiomyoma, it has been graded into 8. 0, 1, 2, 3, 4, 5, 6, 7, 8. And 0 is what? It is completely inside the cavity. It is pedunculated intracavity. Pedunculated intracavitary lesion. So basically, this is the uterus. And if the fibroid is completely like this, a pedunculated submucous fibroid, this becomes 0. Correct? This becomes 0. Now, if this fibroid is less than 50% myometrium, little bit is going into the myometrium. So, less than 50% only going into the myometrium, it becomes 1. More than or equal to 50%, it becomes 2. So, mostly if at all you're getting question, they will give 50%. So, you will get confused between 1 and 2. So, don't get confused. 50% is also 2. 50 or more is 2. 50 or more intramural. Okay. 50 or more intramural is 2. 3 is 100% intramural, but it's contacting the endometrium. 4 is intramural. 5 is subserous, but more than or equal to 50% intramural. 6 is subserous, less than 50% is intramural. And finally, 7 is subserous pedunculated, and 8 is cervical and parasitic fibroids, the other groups. Okay. And here you have to understand that 0, 1, 2, you can do a histoscopic resection. If at all they are causing symptoms. 0, 1, 2, you can do a histoscopic resection provided they are less than 5 centimeter in size. That is also important, provided they are less than 5 centimeter in size. Okay. And you should understand that generally submucous fibroid is the one which impair or reduce fertility. Fibroid, another important area is red degeneration, which generally occurs in pregnancy. So if a pregnant patient comes with pain, low-grade fever, vomiting, she has big fibroid, generally what it turns out to be, it is going to be red degeneration. And how will you manage? You will admit the patient, it is going to be conservative basically. You will give analgesic, you will hydrate well, and after a few days it will settle. Other treatment options of fibroid, this is also very important. So medical, you know that it is tranexamic acid to control the symptoms like heavy menstrual bleed. If at all patient is having pain and bleeding, you can give NSAID. If it's less than 3 centimeter, cavity not distorted, you can give cavity not distorted, LNGIUS you can give. COCP is also another hormonal option for the treatment of fibroid. Now, I just want you to tell. So, some people ask, is there a situation where the fibroid is 4 centimeter or 5 centimeter and you can give LNGIUS? More than 3 centimeter fibroid, but you can give LNGIUS. Is there a situation like that? So, if it is completely intramural fibroid and it is not distorting the cavity, there is no harm. There is no harm in giving. Okay. Now, GnRH agonist. So this is also another option. So it's used as an interim treatment for shrinkage of the fibroid size, maximum for 3 to 6 months. Add back hormone, HRT might be needed if it's prolonged use, and generally it is not for long-term use. Ulipristal acetate also, according to the new guideline, it is restricted use only. It because of the liver injury. So, like only if the patient is not suitable for surgery now, we will postpone the surgery. Till that, there is no harm in using ulipristal acetate, provided you do the LFT monitoring. Okay, that is a must. Okay, whenever you're starting ulipristal, you have to do LFT. So, uterine artery embolization is another situation where the patient wants to retain her fertility, pressure symptoms are there, then uterine artery embolization is generally the answer. And if at all fertility is desired, move cautiously. Generally, you don't choose this option for people who wants fertility. Correct? Okay, fine. Now, next is myomectomy. When will you choose? Generally, myomectomy, wanting fertility, bigger fibroids. But you should explain that there is chance for recurrence of the fibroid and also rupture uterus. If the cavity is entered during myomectomy, go for a elective cesarean section. Definitive treatment completed family. Here also you choose hysterectomy. Okay, definitive treatment completed family. Now, this is again with ulipristal acetate. This point you should remember that it is nowadays used as an intermittent treatment only. LFT, when all you will do, LFT, like in the beginning, when you start the treatment, you have to do. So it is generally given as four courses, right? So monthly for first two courses you have to do. Monthly, every monthly for first two courses you have to do. Then before starting a new course, it is important to do an LFT. And this is a SBA. Generally, sometimes they ask in exam. PAEC, this is basically the benign endometrial change with the usage of ulipristal acetate. Progesterone receptor modulator associated endometrial changes, or PAEC. They are benign changes. It is seen in 60%. So this figure is important. It is seen in 60% of the people. And it's generally reversible. Okay, now we'll focus on fibroids, TOG versus NICE comparison. Okay, this is a very important thing. What you should know. We have a NICE guideline. We have a TOG review on it. So basically, in NICE, they focus on HMB driven management pathway, and in TOG review, they're basically focusing on fertility, pregnancy, the whole fibroid as such. First line is LNG-IUS according to the NICE. Same according to the talk, but it depends on choice also. They emphasize symptom directed choice. Ulipristal restricted use according to the NICE. LFT monitoring is a mandatory thing. And TOG also comment about the PAEC 60% what we discussed, and it is generally reversible in 6 months. More than or equal to 3 centimeter fibroid calls for specialist referral. Tranexamic acid and NSAID may be used as an interim till that. And fibroid, if at all you're planning for myomectomy, better to go for an MRI. If you're going for uterine artery embolization also, MRI mapping is important. Fertility, if the patient wants to preserve fertility, myomectomy is the choice. If it is a submucous fibroid less than 5 centimeter, go for resection. And generally, submucosal resection improves implantation. So if it's a subfertility patient diagnosed with a 3 centimeter submucous fibroid, generally you will go for fibroid resection first. Okay, because it can tamper pregnancy. Imaging, what you will do, first line is always ultrasound. So MRI is done before uterine artery embolization or also myomectomy. This point is important, okay? This talk also focuses on that. So first line is always ultrasound, imaging. MRI is not a must. Only before myomectomy or uterine artery embolization, you are going to do MRI. Okay. Now let's discuss adenomyosis. So basically adenomyosis, generally they are above 40, complaining of heavy menstrual bleed and pain. Heavy menstrual bleed and pain and worsening dysmenorrhea. They generally mention it as worsening dysmenorrhea. On examination, bulky, tender, boggy uterus. If at all you are seeing these terms, choose adenomyosis. First line imaging, always an ultrasound, which is TVS. And in TVS, what are you going to see? You will see heterogeneous myometrium. There can be asymmetry. Posterior part of the uterus is generally more prominent than the anterior part. There can be sometimes myometrial cysts. So these are the classic ultrasound findings in adenomyosis. The gold standard imaging is mentioned as MRI, but the first preferred is always ultrasound, TVS. And MRI, what you're going to see, junctional zone is more than 12 mm. Remember this point, MRI junctional zone more than 12 mm. But the definitive diagnosis, so in the question they will ask, what is the definitive diagnosis of adenomyosis? You're not going to choose ultrasound, MRI, you are going to choose histology after hysterectomy, if that is there in the option, because that's the most definitive thing, right? Correct? It is the most definitive thing. So see the question and then choose the answer. First line treatment, here also it is LNG-IUS. It will reduce HMB and dysmenorrhea. Other medical options are there like tranexamic acid, NSAID, COC, GnRH. All these are options as well. But remember, definitive cure is hysterectomy. Adenomyosis is seen coexisting with other conditions, endometriosis, fibroids, endometrial polyps. So remember that it is coexisting with so many conditions. Let's discuss one question. A 34-year-old woman has HMB and has 2 centimeter submucous fibroid on hysteroscopy. Wishes to conceive. What is the most appropriate treatment? So we have already discussed that if at all there is a submucous fibroid, go for hysteroscopic myomectomy before getting pregnant. Correct? Always choose hysteroscopic myomectomy. So well, now we covered the second important topic as well as adenomyosis. Now let's focus on endometriosis. This also is a very important exam tested area. So basically, in endometriosis, you all know that the typical symptoms of endometriosis, right? Classical DDD, that is dysmenorrhea, dyspareunia, there is dysuria, dyschezia, chronic pelvic pain, subfertility. So all these are symptoms of endometriosis. And generally in examination, they have a fixed, it is fixed usually, retroverted uterus. Might be some adnexal mass is there if she's having chocolate cyst. There can be tender uterosacral nodules also. Okay, so this is the typical examination finding of endometriosis. MRI can be used to understand whether there is deep infiltrating endometriosis or not. So if you're suspecting any deep infiltrating endometriosis, for example, the patient is having lots of bowel symptoms, bladder symptoms. So, or in ultrasound, you're seeing hydronephrosis. So you're suspecting deep endometriosis here. Always go for an MRI. Always go for an MRI if you're suspecting deep endometriosis. Don't skip MRI there. Gold standard, what is the gold standard, especially to diagnose the peritoneal disease? It is laparoscopy. Okay, plus or minus histology, but don't delay the treatment telling I want to do laparoscopy and confirm. Don't wait for laparoscopy. You can start the treatment. The patient will show improvement, right? You can start empirical treatment, but it is considered as the gold standard is laparoscopy. First line TVS definitely, but gold standard is always laparoscopy. What about CA125? It may be raised, okay, in endometriosis, but it's not a diagnostic tool because it's not specific. It is raised in many other conditions also. Now, this is a comparison of endometriosis NICE versus ESHRE. This is important. So, in NICE, they say that consider laparoscopy as gold standard, but don't delay treatment. Okay. And ESHRE, they say that the clinical and imaging, they are acceptable, but laparoscopy is not mandatory according to ESHRE. It is not mandatory. But here it says that, NICE says that it is considered as gold standard, but don't wait to start treatment telling I want to do laparoscopy. Imaging, both the one says TVS as the first line. ESHRE focuses on a expanded role of imaging, like they say TVS plus MRI. Empirical treatment with hormones, both the guidelines accepts. First line medical is always COCP or progesterone. Second line is GnRH agonist plus add-back therapy, and ESHRE also focuses on antagonist. Fertility required means we have to refer, like in certain situation, if there is an endometrial cyst with pain. So generally for more than 3 centimeter with severe pain, not resolving with other medications, you may go for cystectomy. Depending on the scenario actually. For fertility also, the NICE guideline says it is like we can consider surgery, that is cystectomy, if it is more than 4 centimeter. Fine, if it's more than 4 centimeter. But ESHRE says that if you do repeated ovarian surgery, it will lead to decreased ovarian reserve. Okay, so they directly, if the patient wants fertility, they directly focuses on ART. So basically, it's surgery bar ART. Depending on the situation, you will do. If the patient wants to conceive and she's having an endometrial cyst, you want to avoid repeated surgery and you want to preserve her ovarian reserve. In such cases, directly go for ART rather than going for cystectomy and ART. Go for direct ART. So ESHRE basically focuses on direct ART without surgery. Why? Because they want to preserve the ovarian reserve. If at all you are doing surgery, it is always cystectomy, not drainage. Go for cystectomy, correct? Now, this area is also a important area, like for endometriosis, medical and surgical management. Almost the same thing only. Analgesia is basically paracetamol, NSAID you will give as the first line. Hormonal alternatives like COCP are there. GnRH may be added. This is the second line. Antagonist role is also mentioned. Finally comes the role of surgery, where generally you do cystectomy or in endometriosis, otherwise if there is an implant, excision biopsy should be done. And this is said to improve the pain as well as fertility. If endometrioma is there, go for cystectomy rather than drainage. And always remember to counsel about ovarian reserve risk. If at all you're doing surgery and the patient is young patient, tell her that this surgery might reduce your ovarian reserve. So patient has the right to know about that. And deep endometriosis, go for an MRI and also should be referred. Should be seen by a specialist. Okay, should be seen by a specialist. This is important. MDT involvement is mandatory here. So if for fertility, you will refer them to the fertility specialist. Okay. And if at all the patient is wanting fertility, don't start hormones. This rule you must be knowing. If the patient is wanting fertility, never start hormones. So let's discuss this question. Endometriosis, SBA. A 29-year-old has cyclical pelvic pain, dyspareunia. TVS is normal and she's trying to conceive. She's not trying to conceive, sorry. So what is the appropriate treatment? So what you will do? You can directly start hormones. Need not do laparoscopy and confirm. You can directly start hormones. So both the guidelines gives importance to starting hormones. So it's said that you're doubting endometriosis. You're not sure. The patient is having triad symptoms and all. So it's okay that you give a 3-month cycle and see. OCP 3-month cycle you can just give and see whether the patient is responding. Okay, now some important points with regards to PCOS. So all of you must be knowing that PCOS term has changed now. It has become polyendocrine metabolic ovarian syndrome. So basically you should know about the Rotterdam's criteria. So 2 of the 3 is required. So oligobar anovulation, which means that patient is having irregular periods. Hyperandrogenism, it can be clinical like hirsutism or acne, or biochemical like increase in testosterone. And the ultrasound is showing polycystic ovaries. So the earlier it said that more than or equal to 20 follicles per ovary, or ovarian volume more than or equal to 10 ml. Okay, so this is the number of follicles per ovary or ovarian volume more than or equal to 10 ml. This whole thing is the Rotterdam's criteria. So any of the 2 of these 3, if it is present, after excluding other causes, you can diagnose PCOS. And remember, in adolescent age group, ultrasound is not mandatory. Why? Because see, multifollicular ovaries are generally considered normal in adolescents. Okay, so if at all they have ovulation or anovulation or hyperandrogenism, then you can diagnose PCOS just with these 2 symptoms. Okay, so for adolescent, ultrasound is not mandatory. So don't forget to exclude the other condition. Also, that is also very important. Don't forget this. That means you have to do the thyroid if it's required, prolactin if it's required, 17-hydroxyprogesterone, that means you have to rule out the congenital adrenal hyperplasia. If the testosterone is more than 5 nanomole per liter, you have to think about androgen secreting tumors. So make sure that you rule out all these conditions also. Now, coming to the PCOS, the recent criteria in 2023, there was a new guideline which was released, and according to that, the triad is the same. Okay, like we discussed in Rotogram, two of the three, and an oligo or anovulation plus hyperandrogenism plus PCOS in the ovaries, polycystic ovarian morphology in the ultrasound. So if two of three are there, you can diagnose. Say, X-ray also focuses on the same, but the number of follicle is different here. So older guideline says more than or equal to 12 follicles per ovary, and the new guideline says it is 20 follicles per ovary. Okay, that is the difference. Just note this point, all of you. And AMH is not used, okay? Rotogram doesn't use AMH. And Eshrey says that AMH can replace ultrasound for polycystic ovarian morphology, but not in adolescence, okay? Not in adolescence, but Eshrey says that AMH can replace ultrasound for PCOM. Adolescent ultrasound are often lead to overdiagnosis, and very important that should not use ultrasound or AMH according to Eshrey in adolescent groups. Fertility first line, see, according to the older, it was said clomiphene as method of ovulation induction. But letrozole is the first line according to Eshrey, and also the new guideline released on fertility also says that letrozole can be used, because earlier it was not used, but nowadays this can be used. Don't forget this. Letrozole can be used as a first line. And metabolic screening is mandatory according to the older as well as the newer criteria. And there is a good focus on GTT, cardiovascular diseases, non alcoholic fatty liver diseases, obstructive sleep apnea, and mental health. So, patient has to be referred to rule out OSA according to the symptoms. If there is snoring, mental health evaluation. Sometimes you will get questions here. Mental health evaluation for PCOS, that is also mandatory. OGTT often comes, okay? So that is also important. And OGTT generally we repeat it annually, and sometimes 3 yearly also we can repeat. GDM patients, like they are more prone to get GDM. So OGTT in pregnancy also is done. Obesity or insulin resistance, yes, it is if at all obesity or insulin resistance is there, first line is always weight reduction, lifestyle modification. That is the first line. Focus on non-alcoholic fatty liver diseases. So if at all there is deranged LFT, you will think about this. And hypertension, hyperlipidemia, and hypercholesterolemia, all this dyslipidemia, all this condition, suspect cardiovascular complications. And in PCOS, because of the unopposed estrogen exposure, there is an increase in the endometrial thickness, and there is chance for endometrial hyperplasia, and long-term endometrial CA risk is also there with PCOS. So which cancer has the risk? I mean, in PCOS, which cancer is associated with PCOS? The answer is going to be endometrial CA. So long-term risk basically. And screen for anxiety, depression, which I have already mentioned. Now let's discuss about the treatment, fertility treatment. PCOS. So PCOS and anovulatory fertility. If the patient, you're seeing a patient, her BMI is 40, don't go for ovulation induction directly. Choose lifestyle modification and reduction in weight. So one option, somewhere they will be mentioned her BMI is 35. So you will choose your answer as letrozole or clomiphene, and your answer becomes wrong. Why? Because lifestyle modification and reduction of weight will lead to spontaneous restoration of ovulation. So always try this first, and then only you go for induction. And nowadays, as I told, letrozole is the first line. Second line is clomiphene. Without metformin you may use. And sometimes we can go for laparoscopic ovarian drilling or gonadotropins. Okay, especially if there is resistance, clomiphene resistance, then you can use gonadotropins or laparoscopic ovarian drillings. So generally it is done for thin patients. Okay, laparoscopic ovarian drilling. Okay, now discussing about hirsutism and endometrial protection. So basically for hirsutism, you can give anti-androgen containing OCP, and cosmetic measures like laser electrolysis are generally advised. Anti-androgens like spironolactone can be used. Eflornithine is another cream, local cream which is used. And response time generally is 6 to 9 months. Okay. And endometrial protection, make sure that in PCOS, if she's not getting periods, at least 3 months you have to give withdrawal bleed. Otherwise, there is chance for endometrial hyperplasia and there can be risks. So never forget to give 3 monthly withdrawal bleed to a patient who's having amenorrhea. This is for her endometrial protection. So you should know that chronic anovulation leads to unopposed estrogen and hyperplasia, which may have a cancer risk. And investigations, TVS biopsy, prolonged amenorrhea plus thickened endometrium. Okay, this is important. So thickened endometrium, PCOS, prolonged amenorrhea needs endometrial assessment. So she will require an endometrial biopsy. Okay, now let's discuss a question. A 28-year-old patient with PCOS, BMI 29, has anovulatory subfertility. She lost 6% body weight without restoring ovulation. Partner's semen is normal. Tubes are patent. So what is the next thing? You will go for induction, right? Ovulation induction. And according to the new guideline, latest guideline, letrozole is the first line for induction. Okay, now let's focus on this amenorrhea. This is also a very important area. You will get lots of questions. So basically, this amenorrhea thing focuses on few things. One is MRKH, Mertens-Rockeston-Kuster-Hauser syndrome. Second one is androgen insensitivity syndrome or AIS, Turner's, Sway's. These are the things which this amenorrhea topic focus on. So basically, you will get questions like when will you investigate a patient with primary amenorrhea? So if the patient is not getting any periods by 15 years and no secondary sexual characters by 13 years. If the patient is having, if the patient is not getting periods, she's having secondary sexual characters like breast development is there, axillary hair is there, pubic hair is there, then you can be little relaxed, start investigating by 15. But if there is no secondary sexual character, if there are no characters like pubic hair, axillary hair, she's not getting periods, start investigation by 13. So 13, 15, this you should remember. Secondary amenorrhea means there is no menses for 6 months or more. So patients with oligomenorrhea, when will you call them secondary amenorrhea? Patients with oligomenorrhea already might be getting delayed periods, no? So for them, the definition is no menses for 12 months. Okay, people with oligomenorrhea, if they are not getting periods for 12 months, you will call it as secondary amenorrhea. Other people by 6 months, if they are not getting period, then you can call it secondary amenorrhea. Investigations are very important. Whenever a patient comes with amenorrhea, do UPT, UPT, UPT. Don't forget about UPT. It is very important. Okay. Generally, we tend to forget. Don't do that. Pregnancy test is the most important thing to do. Okay. Then, okay, if it's secondary amenorrhea, generally, other hormone testing like FSH, LH. If the patient is having any hyperprolactinemia symptoms, check prolactin, check thyroid. Hirsutism, if the patient is having any abnormal features like hair growth and all, go for testosterone evaluation also. So in primary amenorrhea, if the patient is coming, one important history what you will ask is cyclical pain. Cyclical pain, this is very important. So what are you trying to rule out? You're basically trying to rule out cryptomenorrhea. Cryptomenorrhea. So you have to examine the patient. So if it is imperforate hymen, generally it is mentioned as a bulging bluish membrane. If it is mentioned as pink colored membrane or something, if it's pink colored, select transverse septum. Transverse vaginal septum, pink color. Imperforate hymen, bluish color. These two are different. Okay. And mostly you will get questions also. Mostly you will get questions. Transverse vaginal septum and imperforate hymen. Imperforate hymen blue, transverse vaginal septum pink. There is difference. Vaginal septum can be upper, middle, or lower, right? Upper, middle, or lower. Out of this, the most common is upper. Most common located site is upper. And the most difficult to treat is also upper. Okay. So upper is the most common site. Don't forget that. And if a patient with primary amenorrhea comes, generally after assessing symptoms, you will examine the patient, see for the breast, axillary hair, pubic hair, secondary sexual characters are there or not. Do a genital examination, whether it's a blind ending vagina. You will get an idea. Then what is the next investigation? What you have to do? It is always an ultrasound, correct? It is always an ultrasound. You will do an ultrasound and see whether uterus is present or not. Uterus present or not is very important because your diagnosis will depend on that. So you see ultrasound whether uterus is present or not. Next thing is karyotyping. So primary amenorrhea, generally history examination, ultrasound, karyotyping. With this investigation, you should be able to diagnose. So some important points regarding some conditions. As I told you, primary amenorrhea is about all this condition. So let's discuss MRKH first. In MRKH, generally what is the scenario like? The patient is coming with primary amenorrhea and uterus on ultrasound will be absent. Blind ending vagina. Blind ending vagina, uterus absent. Secondary sexual characters completely normal. So absent uterus, normal secondary sexual characters, blind ending vagina, no uterus, choose MRKH and karyotyping, it will be 46XX. So absent uterus, blind ending vagina, present secondary sexual characters, and 46XX as karyotype, choose MRKH. Because basically here the Mullerian structures are absent. That is the only problem. Her ovaries will be normal. Ovaries will be normal here, okay? MRKH. 46XX, right? Ovaries will be normal. Only thing is uterus will be absent. So what is the fertility option for this patient, MRKH? She has her own ovaries, so she can use her own eggs and go for surrogacy. So she can use her own eggs with surrogacy. Next important thing is Turner. Turner is 45X and generally like they are mentioned to have short neck, webbed neck, and they'll have streak ovaries. So FSH will be generally elevated here. So Turner also they generally go for surrogacy. They have uterus, but uterus is usually infantile uterus. Mosaic Turner, sometimes spontaneous pregnancy is also possible. And also, like if at all she gets pregnant, you have to see for any heart conditions like coarctation of aorta, bicuspid valves. Screen for that. Aortic diameter has to be measured. So it is going to be an MDT management, mosaic with pregnancy. Now, AIS, androgen insensitivity syndrome. Here, the scenario will be the patient will be coming with primary amenorrhea, no doubt. Patient will be coming with primary amenorrhea. On examination, blind ending vagina. It is like MRKH only, no? Blind ending vagina. How are you going to differentiate? In MRKH, I told secondary sexual characters are present. In AIS, the pubic hair and the axillary hair are sparse. Pubic hair, axillary hair are sparse. But breast is good. Breast development is good. Why? Basically, what happens in AIS? In AIS, basically there is problem at the receptor level of the androgen. Testosterone is present in the body, but it is not able to show its action because of the receptor defect. So what happens? So testis is there. It is basically 46XY people. 46XY people, testis is there and it is producing testosterone also and it is producing AMH also, anti-Mullerian hormone also. So because testosterone is being produced, It is supposed to have male action, but it is not able to act. Why? Because there is problem at the receptor level. But AMH can act. AMH is also being produced. So AMH can act, and that is why there is no uterus. Okay, that is why the Mullerian structures disappear because of the action of AMH. However, because testosterone is not able to show its effect because of the receptor problem, there is sparse hair, pubic hair, sparse axillary hair. Why breast development is good? In AIS, the testosterone in the body gets converted to estrogen. Testosterone in the body will get converted to estrogen and it will act on the breast, and breast development is generally good. So don't get confused. See the karyotyping. If they have not mentioned the karyotyping, see for secondary sexual character. Normal breast, sparse axillary and pubic hair, choose AIS. Now, what is Swayers then? Swayers is also 46XY. Then how will you differentiate? So in Swayers, uterus is generally present. Uterus is generally present. Why? Because they have male gonads, but they are streak gonads. It is like Turner's in female, gonadal dysgenesis in male, it is called as Swayers. Streak gonads will be there. So that is why there is no testosterone, there is no AMH. So because there is no AMH, the uterus will be present. Uterus won't disappear. Okay. So generally, Swayers means they will come with primary amenorrhea, and for them, uterus will be present, and 46XY they would have mentioned. Choose your answer as Swayers. So you should understand the difference between MRKH, AIS and Swayers. This is a very question-prone area. Now, what about Asherman? Asherman generally causes secondary amenorrhea, and the treatment for Asherman is curettage, adissiolysis, adissiolysis. The risk factors are post-curettage, some septic abortion. These are the risk factors for Asherman's. And after the adissiolysis, you may put a rubber catheter in the uterus. That is the treatment for Asherman. So, so this also is a very important thing, like type 1, type 2, type 3 anovulation. But type 1, 2, 3. Type 3 means there is ovarian failure. So if there is ovarian failure, what happens? Ovarian failure or premature ovarian insufficiency, what happens? Ovaries are not secreting estrogen. So amount of estrogen will be less. So what happens? The feedback inhibition. FSH, LH becomes high there. So in type 3, there is FSH-LH increase, estrogen will be decreased. So type 2 is like an ovulation, like PCOS conditions, hormones more or less fine only. Type 1 is mainly in the central level. Hypogonadotropic hypogonadism means hypothalamic or hypopituitary. For them, FSH and LH will be less. Estrogen will also be less. And remember, if at all, in any of the situation, testosterone levels are more than 5 nanomole per liter. Exclude tumor or congenital adrenal hyperplasia. Exclude tumor, androgen secreting tumors, and congenital adrenal hyperplasia. So you can go for a 17-OH progesterone and rule out that. Okay, this question, a 16-year-old has primary amenorrhea. She is tall, normal breast development, short blind ending vagina, but no axillary or pubic hair. The typical scenario which I discussed. So primary amenorrhea is there, breast normal, short ending vagina, secondary sexual characters like axillary pubic hair absent. Breast is, however, good development. And when ultrasound is done, uterus is absent. Answer is very simple, and it is complete androgen insensitivity syndrome. So we discussed few topics. Now let's go to the next topic. This is also a very important topic, chronic pelvic pain. So the incidence is 1 in 6. Okay, 1 in 6 female, that question will come. That figure is very important. See, basically, if there is chronic pelvic pain, there should be some reasons for that, right? So chronic pelvic pain, it's defined as pain more than or equal to 6 months. Should not be cyclical. Okay, and it requires MDT for the management. Should not be associated with pregnancy, should not be associated with pregnancy, and should not be cyclical also, and it should be there for more than or equal to 6 months for you to call it as chronic pelvic pain. Now, what are the conditions? One is endometriosis or adenomyosis, and here basically there will be cyclical pain. Like what you can do is a therapeutic trial of ovarian suppression for 3 to 6 months. So if a patient comes with chronic pelvic pain, you're not sure whether it's due to endometriosis or adenomyosis or some PID, you're not sure, or some other causes. But it's okay that you need not diagnose what it is. You need not go for a laparoscopy itself. You can try with hormones for 3 to 6 months and see. Initially you will give analgesics, and if there is no relief, you can go for a complete a combined OCP for 3 to 6 months to see if there is relief or not. So you will get question, before laparoscopy, can we give hormones or not? We can give a therapeutic trial, no doubt on that. Bladder pain syndrome, basically here the patient will, that is also another cause, okay? Here you have to ask whether she's having pain and it is getting relieved on passing urine. That is the typical term, relieved on passing urine. So ask her about her urine frequency, do a urine RE, give her a bladder diary, which is very important, and urology referral also. IBS is another reason for chronic pelvic pain. So Rome's criteria is there to diagnose. Mebiverin is usually given as a treatment here. Musculoskeletal or nerve entrapment. So this is also a very important area, nerve entrapment. So after cesarean section, fan and seals incision will cause entrapment, nerve entrapment. The trigger points are there. So physiotherapy is generally given. And also sometimes gabapentin, amitriptyline can be given for neurological pain. Psychosocial, like history of abuse or any mood problems, is also a reason for chronic pelvic pain. So you can give CBT also in such situation. Investigation. So if a patient comes with chronic pelvic pain, what all investigations are you going to do? Ultrasound, yes, it is must. Rule out endometriosis, adenomyosis, any cause related to that. Infections is the next thing. STI screening is also another investigation. If nothing you can find out, you can give a trial for 3 months of hormones and see. You can simultaneously start with other treatment also. If still the patient is not having any relief, you have to go for the second line, which is the diagnostic laparoscopy. Okay, diagnostic laparoscopy. But before laparoscopy, you have to tell the patient there is 50% chance that laparoscopy will turn out to be normal. You won't be able to diagnose what is causing her pain. Okay, sometimes 50% will come as normal and you have to tell that to the patient. That is a must. Avoid repeated laparoscopies without new indication. Okay, so you should remember that CPP is multifactorial. Give her a symptom diary of 2 to 3 cycles. Okay, so bladder diary, symptom diary, and PMS also 2-cycle diary is there. Okay, remember all these diaries. Write it somewhere. 33-year-old patient has 8 months of cyclical pelvic pain. Examination ultrasound normal. What is the important next step? I told you we can give analgesics plus a trial of hormones for 3 to 6 months. Okay. So first you will give analgesic. If it's cyclical pelvic pain, you can give hormone trial for 3 to 6 months. Okay. Now we'll focus on the next important topic, which are the ovarian cysts. So here basically we will focus on, we'll try to revise this now. So we discussed about HMB, fibroid, endometriosis, chronic pelvic pain, adenomyosis. Now coming to the next topic, which is ovarian cyst. Here we will discuss premenopausal cyst, postmenopausal cyst, cyst in adolescent and children, and cyst in pregnancy also. Okay. Now. So basically this is about pre-menopausal cyst. And in premenopausal cyst, basically this you're supposed to know the size of the cyst, how it is classified, and what is the follow-up required. So basically in premenopausal age group, if it's a simple cyst, okay, simple cyst, less than 5 centimeter. Less than 5 centimeter, no need for follow-up. Less than 5 means premenopausal, there is no need to follow up. Generally, it is supposed to resolve in 2 to 3 cycles. If it is 5 to 7 centimeter, yearly follow-up with ultrasound is required. Yearly follow-up. More than 7 centimeter, they might require further imaging like MRI or surgery. But in question, you will get 5 centimeter and 7 centimeter and you will get confused. Oh my God, what should I choose? So remember, including 5 and including 7, it is yearly follow-up. It is only less than 5 which requires no follow-up and more than 7 which requires MRI and surgery. Okay, 5 to 7, including 5 and 7, it is yearly follow-up. Remember that point. Now, what about the tumor markers? See, in premenopausal cyst, CA125 doesn't have much role. So if it's less than 40 years, you have to focus on other tumor markers, especially if it is a complex cyst. Okay, less than 40 years, complex cyst, you have to do LDH, AFP, HCG because germ cell tumors are very common in this age group. Rule out germ cell tumors here by doing these hormones. Okay, so then like if it is a complex cyst, hormone assessment you have done, then if at all you're suspecting some problem, you can refer them to the gynae onco team and MRI is generally, MRI or CT or MRI is generally required. Coming to the surgery of premenopausal cyst, simple cyst, we are focusing on simple cyst now. So generally laparoscopic cystectomy is preferred. Okay, we will try to preserve the ovarian tissue. Why? Because they're premenopausal age group, right? That is why. Laparoscopic cystectomy is generally preferred here. Aspiration, not recommended because there is recurrence chance. Generally, what happens with premenopausal cyst, suppose a lady comes to you, she's 18-year-old, she wants to give her exam and there is a big cyst. So you did an ultrasound, you told that, okay, this is a big cyst of 12 to 15 centimeter in size. We have to get it removed. We have to do surgery. She says that, no, I want to wait. So what you have to counsel? Bigger cyst, generally there is chance for torsion, rupture, infection, hemorrhage. Okay, there is chance for all this complication. If you're suspecting any of this complication, it requires urgent assessment. If she's coming with acute pain, it might be a torsion and it requires urgent intervention. Okay, so remember these complications. Now, let's discuss about postmenopausal cyst. Okay, see here. Okay, I'll just try to erase this because it is causing disturbance. Fine. Okay. Now, regarding postmenopausal cyst, yes, I think this the tables are made according to the older criteria because the new guideline says different. So, new guideline says that postmenopausal cyst less than 3 centimeter, less than or equal to 3 centimeter, do not require any follow-up. Postmenopausal cyst less than or equal to 3 centimeter do not require any follow-up. Okay, it is not 1 centimeter, it is less than or equal to 3 centimeter. And see, generally, if you come across a postmenopausal cyst and if it is more than 3 centimeter, then you have to start evaluating the patient. Less than or equal to 3 centimeter, unilocular cyst, if it is simple cyst, unilateral cyst, does not contain any solid area, no need to follow up. Okay. But if it's otherwise, then you have to see many things. Like, first of all, what you will see. If at all you see an ovarian cyst, postmenopausal ovarian cyst, you will do you will see CA125, you will do a TVS or a plus or minus TAS, and then you will calculate RMI. So here also, mostly you will get questions like a postmenopausal lady suspecting cyst or coming with vague gastrointestinal symptom. What is the first investigation which you will do? First, you're suspecting postmenopausal ovarian cyst, first investigation. So generally, you will think that it is ultrasound. Correct? We all will think it is ultrasound. But it is not so according to your guideline. It is CA125. That is the first thing to do. Okay? Don't get confused. First thing to do is CA125, then you go for imaging, which is generally TVS plus or minus TAS. Okay. After that, you calculate the risk of malignancy index. Okay, risk of malignancy index. So how are you going to calculate the risk of malignancy index? Basically, what you will do is you will multiply the ultrasound score into M is the menopausal score, and CA125, whatever is the value, you will write that. Okay, RMI is very important. U into M into CA125. So CA125 130 means you will put 130 here. U is the ultrasound scoring. M is the menopausal scoring. So M is for premenopausal, you will give 1 score. For postmenopausal ladies, you will give 3 score. Okay, M is simple. Postmenopausal 3, premenopausal 1. What about ultrasound? So if at all ultrasound is there, see for few features like if whether the cyst is multilocular or not. Multilocular or not. If it's there, you give 1 point. Solid areas are present or not. If it is there, you give the next point. Metastasis is there or not. If it is there, you give the third point. Bilaterality, ascites. So 5 points are there. Multilocularity, solid areas, mets, ascites, and bilaterality. Accordingly, you give 1 score each. Then you calculate everything. And if you're getting the total score as 1, if only one feature is there, means your total score will be 1. If 2 to 5 are there, means total scoring will be 3. So only 1 and 3 scorings are there for ultrasound. If only 1 point is there, suppose it's only multilocular, rest everything is fine. Her score will be 1. Suppose she's having multilocular cyst, solid area. So the score becomes 2. Total score will be 2. She's having multilocularity, solid areas and mets also. Even though 3 points are there, the total scoring will be 3. So I think I told it wrong. It is 3, okay? 2 to 5 points are there means it is the scoring is 3, not 1. If only 1 point is there, scoring is 1. Okay? So ultrasound, again I will repeat, you see for 5 things. Multilocularity, bilaterality, solid areas, mets and ascites. If 1 is there, you give scoring as 1. Ultrasound scoring will be 1. If no points are there, it will be 0. If 2 or more points are there, 2 to 5 points are there, then also the scoring will be 3. Okay, it will be 3. So ultrasound is over. M score is over. Then CA125, whatever value is there, you just write it and multiply everything. You will get the total RMI score. Now, cyst less than or equal to 3 centimeter, I told you it is not 1, it is 3 according to the new guideline, and it is insignificant, and those patients doesn't require any follow-up. Okay, those patients doesn't require any follow-up. However, you should understand that if there is a bigger cyst, for example, so you see the RMI first, no? So according to the RMI, you will classify it into 2 groups. So there is a chart in your guideline. You can go through that. So according to the RMI, if it is less than 200, generally it says that there is low risk. Okay. Generally it says that it is low risk for malignancy. But if it's more than 200, more than or equal to 200 means there is high risk for malignancy. So if it is showing low risk for malignancy, okay. So basically, sorry. So basically, one minute. So basically, RMI less than 200, that is low risk for malignancy. So if it is low risk for malignancy, then what all you have to do? You see whether her cyst is for fulfilling these criteria. One is asymptomatic. The patient is asymptomatic, no symptom. Okay. Asymptomatic. Patient is asymptomatic. Next is it should be simple cyst. It should be a simple cyst. Asymptomatic, simple cyst. Next is more than 3 centimeter and less than or equal to 5 centimeter. Suppose the patient is having 4.5 centimeter cyst. It is fulfilling the criteria. It's simple. It is simple. Patient is asymptomatic. It is more than 3 and less than or equal to 5 also. It is unilateral and unilocular. Okay. So again, I will repeat. So initially you will calculate RMI. If it's coming less than 200, that means she's having low risk for malignancy. Then you see whether the patient is asymptomatic, no symptom at all. Patient is having simple cyst and it should be more than 3 centimeter and less than or equal to 5 centimeter. More than 3 centimeter and less than or equal to 5 centimeter. And it should be unilateral and unilocular. Remember it should be unilateral and unilocular. If at all you are getting such scenarios, then you can go for conservative management. You can go for conservative management. And what is the conservative management? Generally, you will just follow up the patient in 4 to 6 months. You can ask her, you come back after 4 to 6 months. We will repeat a CA-125 and TBS and see whether your symptom is persisting or some cyst is persisting or not. After 4 to 6 months, you are seeing that the cyst is persisting. Then what you will do? Again, one option is you can again reassess after 4 to 6 months. If the second visit she is still having cyst, you have to individualize and discuss the treatment. You can tell her that, see, the cyst is persisting. It has been some time. We did follow up twice. What should we do? Should we remove it or not? You can choose. So explain her the pros and cons and then decide. It is individualized. But if at all during follow-up, you are seeing that the cyst has changed its features, then you have to escalate. Then you have to consider intervention. Now, we discussed so many criteria, no? That it should be simple cyst, more than 3 centimeter, less than or equal to 5 centimeter, unilateral, unilocular. Patient should be asymptomatic. If at all any one feature is there, suppose it is 4 centimeter cyst, unilocular, unilateral and all simple cyst, but patient is having pain. That means she is symptomatic. So if at all any feature what I have mentioned is there, then you can go for intervention, and that is generally laparoscopic bilateral ovariotomy, bilateral oophorectomy. Laparoscopic bilateral oophorectomy. So both the ovaries along with the cyst you are going to remove, and it is going to be laparoscopy. Why laparoscopy? Because the RMI was less than 200. So we discussed the situation where the RMI was less than 200. So RMI more than 200, what are you going to do? RMI more than 200, generally next step is CT, referral to MDT, gynae-oncology. CT first, gynae-oncology first. Then gynae-oncology, those people, the oncology MDT, they will have a review and they will discuss among themselves. And if they are thinking of highly suspicious of ovarian malignancy, a gynecological oncologist, a trained gynecological oncologist will be doing a staging laparotomy. Okay. So basically RMI more than 200. High risk, right? RMI more than 200, high risk. And these people, basically, CT is the first thing what you have to do. After that, it is MDT. Forgive my writing because I'm using my fingers and drawing this. Okay. So here also some questions come. RMI more than 200. Next step to do. In the options, you will have CT and MDT. You will get confused. In your guideline, it is mentioned in a box like this, CT and MDT. So choose CT first, then MDT. Okay. CT first, then MDT. Don't forget this. It is CT first and MDT. Okay. And after MDT, what are you going to do? After MDT, they will discuss and they will see. After MDT, they will discuss among themselves and they will see whether they are suspecting malignancy or not. If there is high suspicion, so high suspicion of malignancy, then what they will do? Best surgery is staging laparotomy. And this should be done by a trained gynae-oncologist. But after MDT, if there is low suspicion of malignancy, they are suspecting malignancy, but it is low suspicion. Then what they have to do is Generally, it is mentioned laparotomy with pelvic clearance, TH with BSO, and they will do a peritoneal cytology, and this can be done by a trained gynecologist. This can be done by a trained gynecologist. So, what is the difference between staging laparotomy and pelvic clearance, TH, BSO, and all? Omentectomy, here also we are doing. The difference comes in the removal of lymph nodes. In staging laparotomy, we have to remove the lymph nodes, pelvic as well as para-aortic, and that a trained gynae oncologist will do. Okay, so this part should be clear. Okay, now some other points I want to discuss is that yes, yeah. So RMI, you should understand that if it is less than 25, this figure is very important, okay? RMI less than 25, the cancer risk is less than 3%. RMI, if it is 25 to 250, there is moderate risk and risk is 20. And RMI more than 250, 75% risk is there. Remember this, these figures will come for exam. And who can do the surgery in these scenarios? RMI less than 25, general gynecologist can do. 25 to 250, if at all we are doing surgery, if at all we are doing surgery, general gynecologist can do. 25 to 250, lead clinician in a cancer unit. More than 250, gynae oncologist in a cancer center. Okay, gynae oncologist in a cancer center. So who are going to do is also important. This can also come as a question. So please note this point. Okay. So rest all things we have discussed, and remember that aspiration generally is not done, but sometimes you will get option, you will get in your question that patient is only symptomatic. You're not suspecting any malignancy, RMI is very less, but she's unfit for the procedure. She's symptomatic, so you have to do laparoscopic bilateral oophorectomy, but she's not fit for that. So in such situation, ultrasound guided aspiration can be considered. Okay. So remember that. Okay, now comes this children and adolescent. This is also very important, children and adolescent. So children and adolescent, the cutoffs of the size are little different. So it is mentioned that cis less than 3 centimeter, no further imaging is required. Remember, for premenopausal cyst, it was less than 5 centimeter, and here it is less than 3 centimeter. No imaging is required. However, for 3 to 5 centimeter, 3 to 5 centimeter, we have to repeat an ultrasound in 3 months. 3 months you are going to repeat your ultrasound. Okay, 3 months. However, 6 to 5 to centimeter, 5 to 7 centimeter, again surveillance in ultrasound with 3 months, or you can consider laparoscopic cystectomy, especially if the patient is symptomatic. Okay. 5 to 7, more than 7 to anyway you are going to do surgery. 5 to 7 centimeter, you can tell the patient that either we can do a surveillance, or if she's symptomatic, we can consider laparoscopic cystectomy. Now, hemorrhagic cyst is another question what is asked in this area, children and adolescent group. So if it's hemorrhage, if it is mentioned hemorrhagic cyst in the question, choose 6 to 8 weeks follow-up. 6 to 8 weeks rescan is the answer. Okay, it is not 3 months, it is 6 to 8 weeks. That is different. If it is a mature cystic teratoma, less than 5 centimeter, we can go for conservative management with serial scans. Only if it is less than 5 centimeter. Okay, remember this figure. And the surgery principle, especially when you are doing cystectomy, is that we have to do ovarian sparing cystectomy. We have to preserve the fertility, and always counsel about the torsion risk, okay, to the patients. Torsion is the complication what we suspect, no? And also remember, if it's a complex cyst, go for all these tumor markers and rule out germ cell tumors also, because that is a very important thing. And adolescent patient coming with severe pain and adnexal mass, you're suspecting torsion. What is the surgery what you're going to do? Another important question area. Always and always you will get question from this area. You are going to do urgent laparoscopy, that you know. But what will you do with the ovary cyst? Will you do ovariotomy? Will you do ovarian cystectomy? So some people will choose ovarian cystectomy. So that you should not do. Why? Because when you remove the cyst also, she is losing good ovarian tissue. So always go for detorsion, even if it appears ischemic. So generally in our practice, do you think we are going to we are going to retain it? Generally, none of us do that. No, we will do laparoscopy. If we see that it is appearing ischemic, we will just do cystectomy or ovariotomy. Okay. But remember in your guideline, laparoscopy is urgent, detorsion is urgent. Don't go for cystectomy. Don't do cystectomy. Even if it is mentioned, it is appearing ischemic in the question, select laparoscopy and detorsion, not cystectomy. Remember this point. It is not cystectomy, even if it appears ischemic. Cystectomy you may do at a later point of time if it is required. Otherwise, if it's not required, you may not do. But detorsion is mandatory there. So this topic is also a little important. I mean, ovarian cyst and pregnancy. So basically, the most common ovarian cyst in pregnancy is corpus luteum, right? Corpus luteum. So they generally resolve by 3 to 4 months. And imaging, generally, you will go for ultrasound. MRI, if at all you are forced to do MRI, don't go for this no gadolinium MRI should be done if characterization is needed. CT, however, should be avoided. Tumor markers, it is highly unreliable in pregnancy. CA125, AFP, HCG are totally unreliable because it is raised in pregnancy. And in pregnancy, however, there is a box in your talk which says that asymptomatic cyst. See, acute abdomen, if the patient is coming in pregnancy, acute abdomen always go for surgery. Okay. So in pregnancy, okay. Acute abdomen. Patient is pregnant, acute abdomen. Okay, patient is symptomatic, acute abdomen. Always go for surgery. Surgery is the answer. Fine, surgery is the answer. Now, she is not symptomatic. Asymptomatic patient. Okay, patient is asymptomatic. Here, what you have to do? You have to see whether it is benign. See whether it is benign. If you're sure, you're doing ultrasound, everything, if you're sure that it is benign means mostly it is a simple cyst and it is less than 5 centimeter. Simple cyst less than 5 centimeter. What you will do? Nothing is needed. No further action is needed if it is less than 5 centimeter. Okay? No action is needed if it is less than 5 centimeter. So we are discussing about asymptomatic patients, right? So asymptomatic patients, simple cyst, less than 5 centimeter, no intervention is required. And it is benign. But if it is more than 5 centimeter, then what you have to do? More than 5 centimeter, or if it is a complex cyst, then a follow-up is required. And how you have to follow up? In 4 to 6 weeks. 4 to 6 weeks. Rescan should be done. So if there is no change in size, then postnatally we have to do a scan again. Postnatally we have to do a scan again if there is no change in size. If it has resolved, no further action is needed. Okay. So benign, it should less than 5 centimeter, nothing is required. More than 5 centimeter and or complex, 4 to 6 weeks you have to rescan. If it is persisting, postpartum we have to, postnatally 6 weeks we have to rescan. Now, if it is not benign, if it is indeterminate, and if you are suspecting malignancy, what you will do? If it is indeterminate, or if you are suspecting malignancy in pregnancy, you can go for MRI. Tumor markers are not reliable in pregnancy, but MRI you can do. And if according to the MRI it is high suspicious of malignancy, means go for surgery. Low suspicious means you can just rescan in 4 to 6 weeks, like what we do for benign cyst more than 5 centimeter. Okay, you can just rescan. High suspicion means you are going to do surgery. So generally it says that surgery is required in 2 conditions. One is if a patient comes with symptoms, acute symptoms. Other is if it is highly suspicious of malignancy. Okay, and remember, persistent complex cyst more than 5 centimeter, always MDT is required. MDT is a must. MDT is a must. Don't forget this, MDT. Okay. And if at all you are doing surgery, ideally second trimester is the ideal period for it. Regardless of this trimester, if it's torsion, you will do the surgery. Suspicious of malignancy means gynae-oncology MDT should be involved. Don't forget that. Okay. So this is all about ovarian cyst in pregnancy. So this is the comparison table of everything whatever discussed so far, but like in a table wise form, it is easy to revise. So just you can take some seconds to go through this table. So this as in a single page, this has been arranged. So just go through this table, all of you. Okay, fine. Now, ovarian cyst, it's a recall table, okay? These signs are very important. Somewhere you will get some questions depending on these terms, okay? So, whirlpool sign, basically these are ultrasound signs. Whirlpool sign, it is seen where? It is seen in torsion. Whirlpool sign in torsion. Cogwheel sign in PID. Ground glass appearance, endometrioma. Spoke wheel appearance, OHSS. Pearl string ovaries, PCOS. Tip of iceberg or dot dash teratoma, struma pearl, struma ovary, honeycomb appearance, mucinous borderline tumor, spider web appearance, hemorrhagic cyst. See, honeycomb and spider web. Don't get confused. Honeycomb is mucinous borderline, spider web is hemorrhagic cyst, and donut sign is ectopic. Donut sign is ectopic. Okay. So, these points are very important. TVS is the single most effective test for characterizing an ovarian mass. This is a favorite line of the examiners. TVS is the single most effective test for characterizing an ovarian mass. Okay. So one thing what I wanted to tell you is that like wherever we discuss this postmenopausal ovarian cyst and all, we are discussing about CT, right? If the RMI is more, you will do CT. So there is a condition where you will choose MRI. What is that condition? Suppose in the question, if it is mentioned that ultrasound is indeterminate ultrasound, then indeterminate imaging, primary imaging, then you may choose the next option as MRI rather than CT. Just remember that point. Okay. 58-year-old postmenopausal woman has a 4 centimeter simple unilocular ovarian cyst, no solid areas, no ascites. Say 125/18, what is the most appropriate management? And it is going to be a conservative management. Suppose in the question you get 58-year-old postmenopausal coming with pain, has 4 centimeter simple unilocular ovarian cyst, everything similar. Then don't write this, okay? Don't choose conservative. Why? Because she has come with pain. She is symptomatic. So she needs interference, and it is going to be bilateral salpingo-oophorectomy in that situation. Endometrial polyps, the next important area, like it is a simple topic. Generally, how these patients will present, they will be presenting with intermenstrual bleed, heavy menstrual bleed, postmenopausal bleeding, subfertility, and sometimes it may be incidentally detected endometrial polyp. First line diagnosis is always ultrasound, you will see incidentally, but you have to confirm. And some situations, if it's more than 1 centimeter or symptomatic polyps, you are going to do histoscopy. You will visualize it and you will remove it. Outpatient histoscopy is enough for that. So in TVS, sometimes focal endometrial thickening will be there. So in those situations, saline sonography will improve the detection rate. Now, tamoxifen is associated with polyp formation and endometrial pathology. Sorry, that is very important. And symptomatic polyps in any groups, you are going to remove it. Premenopausal, postmenopausal. Symptomatic, you remove the polyp. Okay. Postmenopausal, regardless of the size, you are going to remove. Postmenopausal, regardless of the size, if polyp is there, you are going to remove. But premenopausal, only if it's more than 1 centimeter or if it is symptomatic, you are going to remove. Okay. Symptomatic, though, you are going to remove in all age groups. But size, depending on the size, only in premenopausal you can decide. More than 1 centimeter premenopausal, remove. Less than 1 centimeter but asymptomatic, no need to remove. Symptomatic polyps, see and treat is the best thing, and outpatient hysteroscopy. Always exclude malignancy if you are removing. Send for a biopsy. Okay? Send for a biopsy. However, in postmenopausal bleeding, it carries a high risk for malignancy, so remove and histology because the malignancy risk is higher here. Okay, this is the thing what I have told. Asymptomatic premenopausal less than 1 centimeter cyst can be managed conservatively. The cutoff is 1 centimeter. Okay, a question that is a 62-year-old lady, one episode of postmenopausal bleeding, has a 1.5 centimeter endometrial polyp on hysteroscopy. Okay, guys, give me a minute. Okay, sorry for the interference, guys. Okay. Now, okay, 62-year-old lady, one episode of postmenopausal bleeding, has a 1.5 centimeter endometrial polyp on hysteroscopy. So, what is the best management? Yeah, you have to do hysteroscopy, right? Postmenopausal. Postmenopausal means you have to remove, regardless of the size. And it should be sent for histopathology. So, if you get one option, hysteroscopic polypectomy, second option is hysteroscopic polypectomy plus histology. You have to choose this option, okay? Histology plus polypectomy. So go through all the option and then only select your answer. In MRCOG2, more or less all the options are very related. It is very close. So it's very difficult to choose sometimes. So you have to use your logic plus the theory background, whatever you know. Use your logic and then select. And go through all the options. Scrutinize all options properly. Otherwise, you will go wrong. Okay, now let's discuss about AUB, the palm coin, FIGO pathway. And basically, you all must be knowing palm, what is it? So, polyp, adenomyosis, leiomyoma, malignancy, hyperplasia, and non-structural for coin, which includes coagulopathy, ovarian dysfunction, endometrial, iatrogenic, not otherwise classified. Okay, so postmenopausal bleeding, you have to consider it as endometrial carcinoma until proven otherwise. So first investigation, postmenopausal bleeding, first is TVS. If the ET is more than or equal to 4, so it is not just more than 4, it is more than or equal to 4. Okay, the new guideline says more than or equal to 4. If it is so, do a hysteroscopic biopsy. Do a hysteroscopic biopsy provided there is some risk factor. Otherwise, it can be Pipelli biopsy. Okay. Pipelli generally first line for PMB, but if there is any risk factor, go for hysteroscopic biopsy. Now, if you're suspecting malignancy, 2-week referral pathway, it is important. Now, history exam, full blood count, TVS, outpatient hysteroscopy, and if focal IMB or intermenstrual bleeding is there, targeted biopsy is required. That is hysteroscopic biopsy is required. If there is any focal like polyp and all is there, intermenstrual bleed, all those things are there, you have to work on it. So threshold, all of you must be knowing, more than or equal to 4 mm is the cutoff for biopsy. So some points regarding outpatient hysteroscopy, the new guideline is there. Please go through this guideline. You might get questions. Analgesia. Advise NSAID 1 hour prior to procedure. This is the important analgesic given. Technique is vaginoscopy, no touch technique because it reduces pain. Usually miniature hysteroscope is less than or equal to 3.5 mm is used. Okay, normal saline is used. See and treat method. See, diagnose polyp and remove it. So that is employed. If at all the patient is not tolerating outpatient hysteroscopy, then we can advise IP under general anesthesia. Inpatient hysteroscopy under general anesthesia. if the patient is not tolerating. If there is perforation, what is the incidence of perforation? In 1 to 2 in 1,000. 1 to 2 in 1,000. So how to avoid this perforation? We have to do a pervaginal exam, rule out retroversion. If at all you're required to dilate, you dilate. Especially in stenosis and all, you're supposed to dilate the cervix. Remember about vasovagal syncope. So all the crash cart should be there next to the patient to save, which is actually bradycardia and hypotension on cervical instrumentation. So you have to take care of this part. Fluid overload is an important area of examination of exam MRCOG part 2. So that is also a very important thing to revise. So go through the fluid overload and how we will manage also. So this we have already talked. Pipelli versus cystoscopy. What are you going to do? So Pipelli biopsy is generally outpatient blind biopsy technique. Pipelli limitation is that in polyp and people with high risk factors and all, you have to do hysteroscopic guided. So you might miss, no? If it's focal lesions, you might miss with Pipelli. So in those patients, go for hysteroscopy guided. And no blind biopsy in HMB in reproductive age group. It is always hysteroscopy guided biopsy. This I have told in the beginning. Now, if postmenopausal bleeding without any risk factors, no focal pathology and all in the ultrasound, then you can go ahead with Pipelli. But postmenopausal bleeding with risk factors like diabetes, obesity, family history of endometrial CA, history of intake of tamoxifen, go for hysteroscopy guided biopsy. Or if in the postmenopausal bleeding patient in the ultrasound it is showing like irregular endometrium, polyp, fluid filled uterine cavity, in those situations go for hysteroscopy guided biopsy. Pipelli alone is not enough. So if at all you're getting insufficient sample, most common reason for this postmenopausal bleeding is atrophic endometritis, right? Atrophic endometritis is the first cause of postmenopausal bleeding. So in the group of postmenopausal bleeding, 10% will be due to endometrial CA. Figure is important. 10% due to endometrial CA. And if on biopsy you're seeing common atrophic endometritis, but if it is persisting, patient came to you with bleeding, postmenopausal bleeding, you did sampling, it is coming as atrophic endometritis. You counsel the patient and send her back. She came again, 2 to 3 times she's coming. Don't send her back now. Do a hysteroscopy guided biopsy again. That is the point which I wanted to tell. Okay, coming to the next topic. This is also a very important thing, endometrial hyperplasia. The GTG is very important. So basically you have two types, right? Endometrial hyperplasia with atypia, without atypia. So the malignancy cancer risk is very important. So without atypia, there is less than 5% chance to progress to cancer. Most of them will regress. However, 20%, 23% of them, of the patients with atypia will turn into cancer. There is high progression rate, 23%. And 43% of them will have a concurrent cancer at the same time. Means patients without atypia, endometrial hyperplasia without atypia, over 20 years, only less than 5% will progress to cancer. Otherwise, the most of them will regress spontaneously. However, with atypia, 23% of them will progress to cancer. And whenever you diagnose atypia, sometimes endometrial cancer might be hiding. Okay, same time only 43%. Suppose you will get the sampling result as endometrial hyperplasia with atypia. The patient agreed for hysterectomy. You did hysterectomy, and the hysterectomy in 43% of the patients you are going to get the diagnosis as endometrial cancer. Okay, so there is chance for 43% concurrent endometrial CA at the time of diagnosis of atypia and 4% chance of ovarian cancer. This figure is important. 43% endometrial CA, 4% ovarian CA for atypia. And the risk of progression is generally said as 23%. Risk factors include obesity, anovulation, unopposed estrogen, tamoxifen, any granulosa cell tumor, which are estrogen secreting tumors, family history like Lynch syndrome. So, generally, you require histology. And here, remember, outpatient endoscopic biopsy is enough. Only if it is focal or if you're not able to diagnose with outpatient endometrial biopsy, hysteroscopy is considered. And these people generally present with abnormal bleeding, intermenstrual bleed, postmenopausal bleed, unscheduled HRT bleeding, etc. etc. Now, treatment is very important. Okay. So, you should know about the cancer risks, progression of the cancer risk, concurrent endometrial cancer risk, ovarian cancer risk, without atypia. Okay. Without atypia. So, let's discuss this first. So, without atypia, you see for the risk factors, weight, HRT, etc. Without atypia, first line management is always LNG-IUS. Or second line, you can give oral progesterone if at all patient is not willing for LNG-IUS. LNG-IUS, after putting LNG-IUS or oral progesterone, see, LNG-IUS, you may continue after 6 months also if the patient is willing to continue. If the patient wants to remove, you can remove. There is no harm in continuing. But oral progesterone at max, you can give only for 6 months. And what you have to do? You have to take a biopsy at 6 months. 2 negative biopsies 6 months apart, if you are seeing, you can discharge that patient. But some other groups are there. Who are they? Patients with BMI more than or equal to 35 or patients who took oral progesterone. For them, this just 2 sampling is not enough to, 2 negative sampling is not enough to discharge them. They require annual biopsy. So twice you do 6 monthly negative. See whether any risk factor is there. BMI more than or equal to 35 or the patient had taken oral progesterone instead of LNG-IUS. Ask them to come yearly. Okay. Now, if at all during your follow-up, you are seeing that there is no regression or there is relapse or if there is persistent bleeding or the patient is declining surveillance or if at all it is progressing to atypia. Any of this situation, go for hysterectomy. So there is relapse. I mean, you will get 2 negative sample. You discharge the patient. Again, she's coming with bleeding. Again, she's coming with bleeding. Or again, if it is recurring or there is no regression, then always choose hysterectomy. Okay, so these are the points: persistent bleeding, relapse, declining surveillance, progression to atypia, and no regression at 12 months. So two times you sampled, no regression, take her for hysterectomy. Okay. What about removal of ovaries? So it is always hysterectomy with or without BSO depending on the age group. Postmenopausal patients, remove the ovaries. Premenopausal, give them the choice. Atypical, now focus here, atypical hyperplasia. First thing, you have to do hysterectomy only. First line is hysterectomy only. Because why? The cancer risk, concurrent cancer risk itself is 43%. So how can you just like that do the conservative follow-up? So offer her hysterectomy. For postmenopausal, you have to offer bilateral salpingo-oophorectomy. Premenopausal, plus or minus bilateral salpingo-oophorectomy. If they are willing, you remove. However, if she wants her ovaries to be preserved, remove the tubes. That is important. Remove bilateral tubes if you're preserving ovaries in premenopausal age group. Okay. Now, here, if it is atypical hyperplasia and patient wants fertility, she wants to conceive, then what can you do? Okay, you ask her to go to the fertility specialist. You give her Mirena for 3 months. And at 3 months, if you're getting a negative sample, you send her to the fertility specialist. Give her Mirena for 3 months, send her to the fertility specialist and go for ART. Complete the family as soon as possible. And after that, hysterectomy. Hysterectomy you have to do. Okay. But complete her family and it should be very fast. You do give her Mirena. At 3 months, you do a sampling. Single negative sample also if you are getting, send her to the fertility specialist. Not 2 samples. 1 negative sample is enough to send her to the fertility specialist for considering ART. Suppose the patient doesn't want surgery or she's unfit for surgery. You try to counsel her, she's not willing. What will you do? Give her Mirena, but and MDT should be involved. Do an MRI. Why MRI? You have to rule out concurrent endometrial CA. It is 43%, right? Do an MRI, CA 125 because ovarian CA 4%. MDT discussion, and then go for 3 monthly biopsies. 3 monthly biopsies. Okay. Once two negative samples are there, two negative biopsies are obtained, then you go for yearly follow-up, 6 to 12 monthly biopsies. Okay. After two negative biopsies, 3 monthly, then you go for 6 to 12 monthly biopsies because high relapses, high malignancy chances there. If she is willing, do hysterectomy. Once fertility is over, family is complete, do hysterectomy. This is very important. So with hyperplasia, with atypia, without atypia, the management, you should be thorough. You will get lots of questions from this area. So first line, without atypia, LNG IUS for more than or equal to 6 months. The same things whatever we have discussed. If the patient is declining IUS, go for progesterone. And it should not be cyclical, okay? It should be continuous progesterone. At max 6 months you can give this. Without atypia, 6 monthly biopsies, 2 negative means discharge. But BMI more than or equal to 35 or oral progesterone, go for annual long-term follow-up. Without hyperplasia, you have to do hysterectomy if there is progression to atypia, no regression at 12 months, relapse, persistent bleeding, declining surveillance. Atypical hyperplasia, you have to offer total hysterectomy with or without BSO in premenopausal, with BSO in postmenopausal. Laparoscopy is generally preferred here. And once fertility means LNG IUS, exclude cancer by doing MRI CA125, MDT, 3 monthly biopsy, 1 negative biopsy, you send her to the fertility specialist, ART, and do hysterectomy finally once family is complete. Now, HRT associated, never unopposed estrogen with uterus. Always switch to sequential. Why? Because never you should give unopposed estrogen for patients with uterus. She wants HRT. Patient wants HRT. She's having uterus. She wants HRT. You have to give estrogen and progesterone combination. If you just give estrogen, what will happen? She's having uterus, no? It will lead on to unopposed estrogen and there is chance for endometrial hyperplasia and malignancy. So either you go for a continuous combined hormonal pill or a LNG IUS with estrogen alone pill. You give LNG IUS, then estrogen alone pill. That is also fine. Tamoxifen associated, you have to remember that reassess tamoxifen with the oncologist. You have to send them to the oncologist and see that whether she need to continue tamoxifen. Okay. So you have to remember that LNG IUS reduces the polyps. Okay. So if endometrial hyperplasia is confined to a polyp, complete polypectomy plus sample background of endometrium is required to sample. You have to sample everything, not only polypectomy, background endometrium also you have to sample. Then according to the result, you will manage. Okay, so this we have already discussed. Okay, now let's discuss a question. 48-year-old woman, BMI 38, family complete, heavy menstrual bleeding is there, atypical endometrial hyperplasia. Okay, imaging shows no myometrial invasion. Appropriate management. What is appropriate management? So out of this, you can choose hysterectomy. Why? Because atypical. Okay, and family is also complete. 60-year-old patient presents with single episode of postmenopausal bleeding. Ultrasound shows endometrial thickness of 9 mm. Most appropriate next step is very simple. It is hysteroscopic guided biopsy. Okay, hysteroscopic guided biopsy. Okay, now we'll discuss this topic. Like this is a simple topic. You have to remember some particular terms about all these things. Like let us see some scenarios. Like I've just put some catchy lines with the diagnosis. White if in the question you get figure of 8, white atrophic patches, itching with itching. Mostly the diagnosis is lichen sclerosis. White atrophic, figure of 8, itching. Select ultra-potent steroids like clobetasol as the treatment option. If you get terms like Wickham's try, painful erosions, oral lesions associated, it is erosive lichen planus. Treatment is the same, ultra-potent steroid plus emollients also you can give. If there is chronic itching, lichenified skin, stress-related, lichen simplex is the answer. Steroids plus break itch with antihistamines is the usual treatment given. Erythema or edema after irritant exposure, all of you must be knowing it is contact dermatitis, and what you have to do, avoid irritant and steroids, topical steroids. If the patient presents with itch, thick white discharge, satellite lesions, everyone knows this, it is vulvovaginal candidiasis. Treatment also everyone knows it is topical or oral antifungal. Now, if there is a lump, ulcer, induration or some persistent lesion, think about VIN. So you have to exclude VIN by doing a biopsy. Burning soreness, no skin lesion, Q-tip test positive. If you get such words in the question, burning sensation, on touch there is pain, some painful vulva, no lesions are there, vulvodynia. Either it can be provoked or unprovoked. So treatment for vulvodynia is topical anesthetic creams, amitriptyline, physiotherapy, and you have to send the patient for counseling. Okay. Remember, any non-resolving ulcerated indurated lesion, go for biopsy. Why? You have to rule out VIN because it has a higher cancer risk. So let's discuss this SBA. 65-year-old patient has vulval plus white atrophic areas, figure of 8. Just now I told the answer is, so here the treatment they are asking. So it's lichen sclerosis with treated with ultra-potent steroids. So this is a very important area like menopause, like guideline. One new guideline has been added and I'm sure that all of you must have gone through it. So make sure you go through that, okay? So how do you define menopause? So menopause is defined as 12 months of amenorrhea, okay? And 12 months of amenorrhea after cessation of periods. 12 months of amenorrhea, if it's there, generally you can diagnose her as menopause. Perimenopause is the time the patient is getting periods, but it is irregular, okay? 12 months has not occurred after the periods has stopped, but she's getting periods, but she's having symptoms also at that time. Postmenopausal symptoms are there. She's getting irregular cycles. This period is perimenopause. So how do you diagnose menopause? This is a question, routine question. How do you diagnose? Will you say FSH for more than or equal to 45-year-old? Never. For 40, more than or equal to 45 years, more than or equal to, okay, more than or equal to 45 years, it is always clinical. It is always clinical. FSH is not generally required. It is always clinical. But when do you require FSH? FSH is generally required if the age group is less than 45. Less than 45, go for FSH testing. 2 times you will test. Then if it is coming high, you can diagnose menopause. POI, in less than 40 also, 2 times you have to test, 4 to 6 weeks apart. If it is coming more than 25, it is POI. So FSH testing is generally required for people with POI, when you're suspecting POI, and also if it is less than 45 years. Now, do not use FSH on these patients. Why? Because if the patient is on combined hormonal contraception or high dose progesterone, it will affect the FSH value. So never do FSH on people on combined hormonal contraception or high dose progesterone. If at all you are doing, you have to stop it for 4 weeks. Then only you have to do. Otherwise, it will not be correct. And menopause, generally, they complain of vasomotor side effects, mood disorders will be there, sleep disturbance, urogenital symptoms, sexual dysfunction, cognitive dysfunction. These are the usual symptoms. So how are you going to choose the HRT regime? This is important. For menopause people or perimenopause, how are you going to choose? Okay, let us see. Does she have a uterus or not? If she is not having uterus, only estrogen alone HRT is needed, no need for progesterone. Does she have a uterus? No means estrogen only. No confusion. If she has a uterus, you have to give combined. That is a must. Combined estrogen plus progesterone. So you gave combined estrogen progesterone. If she is perimenopausal, it is better to give sequential because monthly withdrawal bleed she will get, no? So you can give sequential. But more than 12 months of menopause, you can give continuous combined. If you give continuous combined, she won't have bleeding. So you want to give estrogen and progesterone, see which, whether she is perimenopausal, is she still bleeding, or how many months since menopause, then you decide. If it's past 12 months, more than 12 months since menopause, continuous combined is enough. But if she's still bleeding, perimenopausal age group, choose sequential, okay? So this is the thing what I have written. So based on the symptoms, on the scenarios, you are going to choose the HRT. This is a question prone area. Vasomotor symptoms, mainly you give HRT. That is the most effective treatment for vasomotor symptoms. Vasomotor symptoms are there, but VTE risk is there. High BMI migraine. In such patients, you can give transdermal estrogen. Plus, for protection of the endometrium, you can give either a micronized progesterone or LNG-IUS. Remember this. Uterus present, you all know we have to give continuous combined or add LNG-IUS or micronized. No uterus means estrogen only is needed. Perimenopausal bleeding, press, sequential combined. Postmenopausal for more than 12 months, I told it is continuous combined. Now, this also you will get a question. Patient with low libido. Low libido, you gave her first line is HRT. First line is HRT. So, this is a question, low libido. So, if at all, in the question they are asking, patient complaining of low libido, what is the first line? Don't choose testosterone. It is first HRT only. First is always HRT. First is always this, okay, HRT. Then second, okay, if there is no relief with HRT, go for testosterone. Then next option, another T you have to remember, tibolone, tibolone. So HRT, testosterone, tibolone. Don't choose testosterone first. Always HRT first. Then in spite of that, if she's having problem, choose transdermal testosterone. Next option is tibolone. Don't forget that. That is an important thing to remember. Okay. Now, low libido despite estrogen, this we already mentioned. Now, vaginal dryness and dyspareunia. Okay. Even if the patient is on HRT, you have to give topical vaginal estrogen. Only vaginal estrogen. Okay. Topical vaginal estrogen. Anxiety related to menopause. Anxiety, CBT. You have to do CBT. So remember all these terms, you will get different scenarios. Okay. Anxiety, if they have mentioned in the question, go for CBT. No. Mild vasomotor symptoms. Okay. And patient is not ready for HRT. Mild vasomotor HRT, patient is not willing or aversion. CBT is the first line, then SSRI or SNRI. SSRI or SNRI. Then you can also choose clonidine, gabapentin, etc. But CBT is the first line, okay? So if in the question you get mild vasomotor symptom, patient not ready for HRT, choose CBT as the first line. Remember SSRI, SNRI are always there. And one point which I want to stress is that whenever you see that patient, any patient taking tamoxifen, and you want to add this drug, don't add SSRI. Instead, you can choose SNRI. Okay? Don't choose SSRI. Instead, you choose SNRI, venlafaxine. So that point you remember. Breast cancer survivor plus severe genitourinary symptom, vaginal dryness and all. What you will do? Breast cancer survivor she is. See, there is no harm giving topical vaginal estrogen once you form an MDT discussion. Along with that, you may give vaginal moisturizers as well. Patch adhesive allergy and uterus is there. Then you can give continuous combined oral HRT. Okay. So these are the scenarios which you should remember. So this risk is very important. Okay. Like breast cancer risk detail, it's combined. Small increase in the risk is there. VT risk, oral, there is increased risk, but transdermal, no increase in risk. So you can use this transdermal if the risk factors for VT are there. So risk factors for VT means use transdermal. Okay. Stroke, small increase in risk is there with oral, especially more than 60. For them also transdermal is better. CHD, no increase if it is started less than 60 years. Okay, within 10-year window of opportunity period. So CHD, you remember this point. Absolute contraindication for HRT. Current breast cancer, past breast cancer, estrogen dependent cancer, undiagnosed vaginal bleed, active VT and active liver disease. All these points you have to remember because you will get different scenarios. See, control BP is not a contraindication. Diabetes is not a contraindication. Smoking, obesity, migraine. All these are not contraindications. You can very well use transdermal. VT, there is no increase in risk with transdermal. So, any patient with VT risk, you can use transdermal. Don't forget that. Okay, this is GSM and bone health. Symptoms, basically, they will complain of dryness, dyspareunia, recurrent UTI and all. The first line is always topical vaginal estrogen. No need for progesterone. Vaginal moisturizer also they can use. And always for bone health, you have to assess the DEXA score. DEXA score has to be assessed. FRAX score, FRAX Q fracture and DEXA T score has to be assessed. T scoring you should know. The levels, the values of T scoring is also an exam question. So if it is less than or equal to 2.5, it is osteoporosis. -1 to -2.5, it is osteopenia. More than or equal to -1, it is normal. So this values, it is important. HRT will reduce the fracture risk when it's taken. First line drug is bisphosphonate. Okay. 52-year-old patient with troublesome hot flushes has a uterus, BMI 33, previous provoked DVT is there. She wants to start HRT. Just now I told it is transdermal estrogen and she has a uterus, so you have to combine it with progesterone. Because VT risk is there, transdermal. Okay, so our final answer is transdermal estrogen plus progesterone. So in menopause, I want to discuss some important points from the new guideline. So you have to remember this like physol intent. Physol intent is the new thing what is used for vasomotor symptoms. If at all the HRT is unsuitable, you can use that physol intent. That is according to the new guideline. And this new guideline gives lots of importance to CBT. Remember that. CBT, they are mainly focusing on CBT. If the patient is having vasomotor symptom, then also HRT plus CBT they are asking. Sleep problems, depressive symptoms and all, go for CBT. And ospemifene is prasterone and ospemifene for genitourinary symptoms. Okay, prasterone and ospemifene. Okay, these are the important changes, additions in the new guidelines. So just remember that. So premature ovarian insufficiency. This is also a very important area, like the diagnostic criteria. So when will you diagnose POI? In the question, you will get 38-year-old lady with no menses. Patient is having hot flushes, symptoms of menopause, and you are doing FSH, it is greater than 25. What is the next step? So option A, you will diagnose POI. Option 2, you will repeat FSH after 4 weeks. Answer is repeat after 4 weeks. Okay. Next step they are asking. So repeat after 4 weeks. Only if two values more than 25 FSH you get after more than or equal to 4 weeks apart, you will diagnose POI. Otherwise, don't diagnose. What is the incidence of POI? It is 1%. 1%. Remember that. Now, what are the causes? Idiopathic, Turner syndrome, Fragile X syndrome, autoimmune cause, chemotherapy, radiotherapy, etc. Most common is idiopathic actually. You won't know the cause. Investigation, yes. Remember, whenever you see a POI case, don't forget to do karyotyping. We have to do karyotyping and exclude any genetic conditions, chromosomal condition. Adrenal thyroid workup is important. DEXA scan, ultrasound. All the investigations are important. Remember all these things. Ultrasound, DEXA scan, thyroid antibodies, adrenal antibodies, karyotyping, all these are important. So what is the treatment what you can give her? You have to give her HRT. You can give it in the form of continuous combined OCP and till the age of natural menopause, which is generally 51 years. So advantage is that it protects bones, cardiovascular system, urogenital system, cognitive function, etc. Remember, you have to do a DEXA baseline. I already discussed among the investigation. Because if you don't treat POI, it will increase the osteoporosis risk and cardiovascular risk also. So DEXA baseline is very important. In POI, remember 5% chance for spontaneous conception is there. This is an important figure for exam. 5% spontaneous conception rate in POI, 5%. And for fertility, what you can offer? Fertility specialist referral, and she can consider donor oocyte. Okay, donor oocyte IVF. See, HRT, if you are not giving continuous combined OCP, other than that, if you're giving the normal HRT, it is not a contraception, okay? HRT is you're giving in low dose. It is never a contraception. If you're giving COCP, it is fine. It is a replacement as well as it is a contraception. But HRT is just a replacement. It is not a contraception. So if she doesn't want pregnancy, add contraception along with HRT. So you have to continue till the age of menopause. That is the key point. So this is the ESHRE guide. New guideline is there of ESHRE. Just summary of that table. The definition is loss of ovarian activity before the age of 40. So what is early ovarian aging? The difference is in premature ovarian insufficiency, less than 40 years, they will get menopause. In early ovarian aging, it is usually early menopause, never less than 40. They might get it less than 45 or something, but it is never less than 40. The incidence of POI is 1%, incidence of early ovarian aging is 10%. Again a question, 1%, 10%. POI people are symptomatic, early ovarian aging, they might not be symptomatic. Okay? It might be an incidental diagnosis. Okay, now coming back to POI HRA, the definition I've already discussed. Diagnostic criteria is same. We have already discussed that. AMH is low or undetectable. Okay, it is a support. It supports, but not diagnostic. If you find that AMH is low or undetectable, it will support your diagnosis. Karyotyping you have to offer to all. Fragile X mutation test offer. Autoimmune screen offer to all. Especially if the patient is symptomatic. Bone DEXA at diagnosis is a mandatory thing. Remember to give vitamin D, calcium intake, weight-bearing exercise. This advice should be given to the patient. Cardiovascular follow-up like BP, BMI, lifestyle, all those things should be followed up. Hormone therapy till the age of natural menopause. So HRT may be for better bone health, cardiovascular health and all. But if contraception is preferred, you can give COCP. Fertility, 5% chance. I have already discussed. If she wants fertility, donor oocyte is the main thing. HRT is never a contraception. If the patient is on HRT, add a good contraception. Okay, this question. 32-year-old, 6 months, amenorrhea plus hot flushes. FSH is 40 on 2 occasions, 5 weeks apart. Does not wish to conceive. What is the most important management step? So you have to give her HRT, right? What HRT you will give? You can give her COCP, right? She does not wish to conceive. So offer HRT, but ideally if COCP is there, that is more preferred. Why? Because she doesn't want contraception. So if you give COCP, it acts as a contraception as well as a replacement. Okay, there comes the end of the topic discussion, and now let's do some random recalls, and after that we will end the session. So endometrial hyperplasia. So basically, the recall scenario and answer we have written. So tamoxifen user. In the question, it is written tamoxifen user, postmenopausal bleed or hyperplasia without atypia, LNG inserted. When do you follow up? So it is repeat biopsy at without atypia, no? So it is 6 months. Okay. 2 times 6 monthly, 2 negative biopsy. And after that, annual follow-up is required. Why? Because she's having risk factor. She's having risk factor. 55-year-old, 9 centimeter complex mass, ascites is there, CA 125 200, more than or equal to 2 ultrasound features are there. So they have asked for RMI calculation. They have written, and what is the management? That is the question. So RMI you have to calculate from the scenario. So ultrasound scoring 2 or more features, no? So 3 is the score, plus postmenopausal 3 is the M, and CA 125 is 200. So total it is making 1800. So this is very high. It requires oncology MDT plus staging. 27-year-old, day 16, ET 14 mm, regular cycles and asymptomatic. So here you can just reassure the patient. You can tell her that it is a normal premenopausal endometrium. 48-year-old with BMI 38. Atypical hyperplasia, family is complete. 48-year-old, BMI 38, high BMI. Atypical hyperplasia, family complete. Offer her hysterectomy with or without BSO. Persuade her for BSO. She's 48. Persuade her for BSO because sometimes 4% ovarian cancer might also be there. 35-year-old PCOS, atypical hyperplasia, wants fertility. So you know the answer. It is Mirena plus 3 monthly, 1 biopsy negative. Then you have to send her for this patient, fertility specialist. Consider ART, and after that you remove her uterus. Do hysterectomy finally. 65-year-old, postmenopausal bleeding. It is 3 mm only. No focal lesion. What is your answer? Reassure. Reassure. ET more than or equal to 4 mm, biopsy. Biopsy is required. Which biopsy? First line is always blind biopsy, Pipelli biopsy. But if she's having risk factors or abnormal ultrasound findings, hysteroscopic biopsy is ideal. So if this patient comes again with bleeding, repeated episodes of bleeding, you have to do biopsy. Okay. Okay, this is another recall. 60-year-old on combined HRT. Vasomotor symptoms are resolved, but persistent low libido is there. I told you already. HRT is already started. So next you have to start testosterone gel. Tibolone is the next thing. 56-year-old past unprovoked DVT. Uterus is intact. Uterus is there. VMS, severe vasomotor symptoms are there. Here though you have to give her HRT. But what HRT is best for her? DVT history. So patch. Uterus is there, no? So you give patch plus IUS or patch plus micronized progesterone. 54-year-old patient, breast cancer survivor, severe dyspareunia and vaginal symptoms, refractory to moisturizer. So you can give her topical vaginal estrogen, but you have to discuss with MDT. 48-year-old, 18 months amenorrhea, intact uterus, patch adhesive allergy. So you have to give her, uterus is there. So definitely combination of estrogen and progesterone. Patch allergy. So give her continuous combined oral HRT. So this scenario is clear. 46-year-old perimenopausal lady, irregular cycles, no withdrawal. She doesn't want withdrawal bleed. So if she doesn't want withdrawal bleed, you have to give her. So here I think it is written wrong. 46-year-old she doesn't want, no withdrawal bleed is wanted, means you are going to give her continuous combined. Otherwise, generally for perimenopausal ladies, you can give her sequential pills. Why? Because there can be, she will have bleedings. She will have withdrawal bleed. 52-year-old, mild VMS. Strong family history of breast cancer. They don't want hormonal. She wants non-hormonal treatment. So I told you in the chart that mild VMS, patient not wanting HRT, always choose CBT. Okay, CBT is the first thing. First line, non-hormonal. So all these points are questions. Now, next. 64-year-old patient, 4 centimeter multiloculated solid cyst, CA 125/50, RMI is high. So you have to do, see, you're sure that it is, RMI is very high. So you're going to do a full staging laparotomy at cancer center. 64-year-old, 6 centimeter simple cyst persisting at 4 months. CA 125 is 5. RMI is less, but since it is more than 5 centimeter, you have to do a surgery. You have to do bilateral salpingo-oophorectomy. Again, 54-year-old, just 2 to 3 centimeter simple cyst. RMI is less. So it seems new guideline says less than or equal to 3 centimeter, no need for follow-up. This is according to the older guideline. The answer given is according to the older guideline. Note this. So 54-year-old, 2 to 3 centimeter, no follow-up is required actually. Less than or equal to 3 centimeter, if it's a simple cyst, no follow-up is required. 64-year-old, incidental 8 mm simple cyst, definitely no follow-up. 65-year-old, complex mass, ascites, omental thickening, high RMI. It requires same answer, full staging at cancer center. A frail 9-year-old lady, not fit for GA. Symptomatic, 10 centimeter simple cyst, RMI is less. So you think it is symptomatic. She requires ideally surgery, but she is frail, 90-year-old. RMI is less, so no suspicion of malignancy. So for these patients who are not fit for GA, frail ladies, you can consider ultrasound guided aspiration. But she should be symptomatic, okay? She should be symptomatic and she should not be fit for GA. Then only you can choose this. 36-year-old patient, 8 months of amenorrhea, FSH is more, 2 times. Low estradiol. POI is the answer. We already discussed 2 values, more than 25, 4 weeks apart. Answer is POI. 16-year-old, oligomenorrhea, BMI 31, acne hirsutism, LH FSH 3:1. Very easy question. It is PCOS. 16-year, primary amenorrhea, short webbed neck, classical, 45X. FSH is high. Turner syndrome is the answer. Now, 26-year-old, rapid virilization, okay? Testosterone is more. Normal 17-hydroxyprogesterone and DHEAS. So, whenever you see this scenario, you have to think about tumor. Testosterone secreting tumors. 16-year-old, primary amenorrhea, tall, absent uterus. Ovaries are present, 46XX. MRKH, very easy. 17-year-old, primary amenorrhea, sparse pubic hair. We already told, sparse pubic hair, 46XY. Inguinal mass, it is androgen insensitivity. So for them, they have testis and sometimes it will be present, it will be undescended. That is why inguinal mass is being mentioned. And you have to do gonadectomy for these patients, but only after good height is attained. So after puberty, you can do gonadectomy. But in Swyer syndrome and partial androgen insensitivity syndrome, the chance for malignancy in the gonad is more. So you have to do immediate gonadectomy. Okay, first you have to do an ultrasound, visualize it. Then you have to do immediate gonadectomy in partial as well as Swayers. In complete, after puberty, you can do gonadectomy. Okay, coming to the last few questions. So, clinical PID, outpatient, gonorrhea risk is there. There is history of travel and unprotected sexual intercourse. What is the treatment? Gonorrhea treatment, all of you must be knowing, ceftriaxone 1 gram IM. Plus, it is PID, clinical PID. So, doxy plus metro, 14 days you may give. So, this is the combination what you're going to give. Uncomplicated chlamydia, doxy post ERCP. Okay. Doxy 100 mg BD for 7 days. That is the first line. Severe inpatient PID. What are you going to give? The patient is having copper T also. So you can give IV Oflox plus IV Metrogyl for 14 days. If it is mild, the IUCD you need not remove. So this is another question prone area. It will be mentioned the patient is having IUCD. Patient is coming with PID. What will you do? You give the treatment for PID, wait for 48 to 78 hours. If it is resolving, no need to remove copper T. No need to remove copper T. Otherwise, if it's worsening, you have to remove copper T. Again, another scenario. A patient is asymptomatic. Copper T is there. And on smear examination, you are seeing actinomyces-like organism. What will you do? Patient is asymptomatic. You are just seeing actinomyces-like organism in the smear. You need not remove. But if she is symptomatic and if it is showing actinomyces, if she is symptomatic, you are suspecting pelvic actinomyces, remove copper T without any delay. Like in PID, no need to wait for 48 to 72 hours. Symptomatic actinomyces, remove copper T immediately and treat. Okay, coming back. Frothing yellow discharge, strawberry cervix, motile protozoa, typical appearance of trichomonas, and answer for treatment is metronidazole 2 gram per oral. Male multiple painful bleeding ulcers, ceftriaxone because you're suspecting chancroid. 10 centimeter TOA not responding to 24-hour IV antibiotics, ultrasound guided transvaginal drainage. That is the answer. Now coming to this set, guys, give me a minute. Okay. Okay, fine. This vulval ulcers and discharge. Okay. If you're seeing single painless indurated ulcer with clean base and raised edges, choose primary syphilis. Palms and soles rashes are mentioned. Condyloma lata, VDRL 1:64, fetal high drops, choose secondary syphilis. Multiple painful ulcers with gray yellow base and bleeds on touch. It is Haemophilus ducreyi chancroid. Frothy yellow discharge, strawberry cervix, again trichomonas. Pregnant painful vesicles, HSV PCR, it is genital herpes. Recurrent oral genital ulcers plus uveitis plus TVT plus pathology, it is Behçet's disease. Okay, this is some random endometrial CA recalls. For stage 1A G1, Pol mutation and MSH2 deficient, multiple classifier. So in this patient, you have to go for genetic counseling. Stage 1A G1, Pol mutant MMR intact, P53, no adjuvant treatment is needed. And stage 1A G1, P53 abnormality means high grade. So EBRT is the treatment. G3 EEC more than 50%, and if you're suspecting nodules, MMRD, you have to go for MDT plus cancer center staging. So this topic will be discussed again with you in your oncology revision marathon. So 35-year-old EC confined to endometrium wanting fertility, you can go for fertility sparing treatment, which is high dose progesterone. 70-year-old stage 3C2 serous tumor P53 abnormality, you have to go for surgery plus adjuvant carboplatin and paclitaxel plus EBRT. Now this is again a cervical screening and CIN recall. So go through the guideline, all of you. So HR HPV positive and cytology normal and previous negatives. In that, you have to choose recall 12 months after repeat HR HPV. So postmenopausal LLETZ for CIN3 already undergone this procedure. Deep margin is involved. So you have to go for re-excision. 35-year-old post-led CIN3, deep margin involved, family is complete. So HRHPV at 6 months. 35-year-old, clear margins. 6 months HRHPV low grade, it is showing low grade, colposcopy is normal. In such situation, recall at 12 months. 28-year-old, 14 weeks pregnant with high grade dyskaryosis. Go for colposcopy and you have to defer LETS postpartum. 26-year-old patient, high grade with visible irregular ulcerated 2 centimeter lesion is an urgent 2-week referral pathway. So, see, must know points is added, like RMI formula is a must. Cutoff of RMI is a must. PCOS, PCOM, ESHRE classification of new classification of more than or equal to 20 follicles. This is important. PCOS fertility, now letrozole is the first line, but before that always consider lifestyle. ET more than or equal to 4 mm, sampling is required. Hyperplasia, atypical, you know this. We have already discussed this point. And HRT plus VTE, patches, select patches. Testosterone secreting tumor, which when you will suspect if this testosterone levels is more than 5 nanomole per liter or rapid viralization is there. POI diagnosis, already we discussed. It is FSH more than 25, 4 weeks apart. And you have to give treatment till the natural age of menopause. So, these are again the same things, whatever we discussed so far. Some important things I have added in the box. You can just go through this. So, same things, every point we discussed before. Okay. This is also important, like we have already discussed this. No blind biopsy, only hysteroscopic guided biopsy in HMB of reproductive age group. First line treatment LNG IUS. More than 3 centimeter HB less than 10.2 milliprostol. Wanting fertility, submucous less than 5 centimeter, choose hysteroscopic myomectomy. Endometriosis plus normal ultrasound. Normal ultrasound does not exclude it. So empirical treatment is a mandatory thing. First line, letrozole, PCOS. PCOS plus prolonged amenorrhea, you have for endometrial protection, you have to give withdrawal bleed. Absent uterus sparse hair 46XY, AIS. Postmenopausal cyst RMI more than 250. Cancer center plus staging. Premenopausal less than 5 centimeter, no follow-up. So postmenopausal bleeding more than or equal to 4 mm biopsy. So the Pearl summary also, everything we have discussed. So I hope this session was useful for you. Please, we have added all the important exam tested areas. Okay, so go through all these things, revise it properly. All the best for your exam. So I'm going to save the chat box and we will get back to you. We will be solving all your queries. So I'm going to save the chat box, okay? Thank you all. Thank you.